And we start with the interesting panel discussion. We know that avian-compatible living donor liver transplant is becoming more common in the scenario of organ shortage and incompatibility. But the interesting part is that we are going to discuss on avian-compatible in scenario of ACLF and ALF. So I would like to invite Dr. Sanjeev Sehgal. He doesn't need any introduction. He's a principal director and head hepatology and liver transplantation at Center of Liver and Biliary Sciences at M.I.C.E Institute of Liver and GI Sciences, M.I.C.E Hospital, Delhi. It's over to you, Dr. Sehgal. Thank you.
Thank you so much for the kind invite and giving me this interesting job of holding a panel discussion on a very interesting topic. We all have been excited about ABOI in compatible transplants. We are doing more and more, and the fact is that the topic we have chosen today, ABOI in ALF and ACLF, is probably the most challenging, and still we are very hesitant to have this panel on. Let me share my slides first. Let's see. Okay, there we go. So I have got a very eminent panelist with me, 2 surgeons and 2 hepatologists, very well balanced. Dr. Shalin Agarwal, who's director in liver transplant and hepatitis surgery at Center of Liver and Biliary Sciences in M.I.C.E. I have Dr. Rakhi Maiwal, additional professor of hepatology at AILBS, very, very active in ICU management of patients, and I'm sure she will contribute to this discussion today. We have Dr. Kaisar Raja, who's a consultant in liver disease and transplantation at Integrated Liver Care Program, Aster CMI, Bangalore. And my dear friend Amit Rastogi, Associate Director of Liver Transplantation and HB Surgery from Medanta. And it's really a pleasure to have all of you here today. Now, how I would frame the discussion today is that I think I've got about 25-30 minutes in hand. I'll present a case which we have seen recently and try and build up on that, on the challenges which we face when we have to do a ABO-compatible transplant for ACLF patient, in particular an ALF. So let me just give a brief of the patient which came to my mind. This is a young boy, 32-year-old, O positive blood group, which is a BMI 21, chronic alcoholic, heavy alcohol actually, and 1 month prior to presentation, he was having pretty good going alcohol intake. And first presentation was in January 2022 with about 4 weeks history of jaundice and distension of abdomen ascites for about 3 to 4 weeks, had pallor, jaundice, edema, had ecchymosis, and his blood reports, if you see the outside hospital and at admission and during our own hospitalization in our hospital here, he persistently had leukocytosis, which actually increased during the hospital stay. His INR was not good. It was on the higher side. Bilirubin peaked to 34. Enzymes, OTPT typical of alcoholic liver disease, alcoholic hepatitis, low albumin, renal function initially preserved. Later on, they were actually not good. Creatine 2.8, and the later part of his stay after 2 weeks, high lactate. These were his, the bilirubin which was rising, the blood count, the TLC which was rising gradually in the hospital stay, INR and creatinine which also shot up later on in the hospital stay. Viral marker were negative, and his cultures essentially were sterile except the procalcitonin which was slightly raised. X-ray and echo essentially fine. A large liver, fatty infiltration, and you can see the liver coming down to the pelvis. And this was a timeline. He was treated with some steroid therapy about 5-6 days outside without much of response. Had HE grade 2, was on various antibiotics, Lola, meropenem, antibiotic, all these typical what we give. Then renal dysfunction, went on to have albumin, terlipressin, and other things. Essentially, he was not doing well. And here we had what we had actually. We had a patient who had acute and chronic liver failure, acute component being alcohol, chronic again alcohol, portal hypertension, AKI, HRS, HE grade 2 to 3, organ failures, liver, coagulation, cerebral, and renal. So if you look at the scores, MELD score 30 to 39, ARC score 10 plus, high cliff ACLF scores, high MDF 110, 113 actually, and high Glasgow alcoholic hepatitis score. So this patient clearly needed a transplant because we had exhausted our medical therapies, and we thought that, well, he's not really, going to be salvaged by medical measures alone. So he was opposed. Let's now not stick to the patient in general. So here we had a challenging situation which we faced day in and day out in our practice. So I'll make it as a more general discussion. If you don't have a blood group compatible donor in this sort of patient, where mentally you are now clear that we need to do a transplant, we have exhausted our possibilities. So how will you proceed? So the challenges which would come in a ABO incompatible LT for ACLF, similar would be for ALF actually, what they would be. So there would be a lot of challenges which one would encounter, and some of them I have just enumerated here. Titer values, rituximab, and poor desaturation, and other measures which we come across. What I'll do is I'll skip that slide. I'll come to the issues now one by one and try and dissect it in the next whatever time we've got, and try to have opinion from the surgeons and from the eminent hepatologists. If you are faced with a situation where you have to go with a ABO incompatible transplant in ACLF like this, how would you approach? So to get the ball rolling, let me start with Amit, my dear old friend. Amit, if you have to take up this call, the time is limited, and you don't have a proper way to desensitize these patients, and you do a titer. So does the quantity of titer, is it 1:256 or 2000 plus? Does it matter in selecting these patients for ABO incompatible transplant? What would your thought and experience in this, Amit?
As you said right from the beginning, this is a difficult situation. We have done ABO incompatible for last few years, and the only thing is we have so far not done ABO incompatible for ALF situation or maybe this kind of situation. So first-hand knowledge probably would not be exactly what we do it for the elective cases. For elective cases, the guidelines are a little more strict and a little more clear. Anything less than 256 is the ideal situation, and more than that is a problem situation, and you bring it down. But then in this situation, it is very difficult. You have to accept whatever it is, but there is a difference if the initial titers are low versus initial titers are high. Initial titers are high, you don't have preparation time, and there is a high chance that there would be problems post-operatively. But if you have to accept, you have to accept. Conceptually, going by the experience of the elective situation, we feel that probably acute or acute and chronic, you can get away, and probably increasingly people are doing it. But this is a situation where you don't want to be in. But given a choice, you have to do it. You can do it. And there would be a difference if the initial titers are high. How do you bring it down? And all those is a subsequent discussion that we would have.
Yeah. I mean, that's a very fair thought. And I think why not have opinion of Shalin, who's my colleague here? I mean, again, a surgeon, very, very eminent surgeon who has a lot of experience. Shalin, what would be your call on this question? Do we have Dr. Shalin on the
Dr. Shalin, I think you need to unmute yourself.
Yeah, I have unmuted. So, Dr. Ashish, thank you very much for inviting me and having me in this meeting. Dr. Sehgal, to answer your question, I kind of partly agree with what Dr. Amit is saying, that yes, one would not like to be in a situation where you have to do an ABO compatible with a sick patient of ACLF. Our own experience of nearly more than 80 ABO incompatible in transplants, the ACLFs are in single digits. But yes, we have done in ACLF, and we didn't want to do them. We were forced to do these situations, but we were very selective. And coming straight away to your question, that would the titer of 1:256 versus 1:2048? Well, this is not it's not black and white. It's a very gray area. Nobody has a clear-cut answer. But in our own experience from elective cases, we have seen that you titer really ones like 256 or 2048 in terms of final outcomes doesn't have a lot of bearing. 2048 comes down rapidly even with 1 or 2 plasmapheresis situations, and we have seen where 256 got stuck at the same level. And the 2048 patient did not have a rapid or uncontrollable rise in titers post-operatively. So I don't think that titers alone, well, it seems like logical that lower titers would have been better, but in actual practice and in our own experience, we have seen that the titer values, see, we follow a cutoff 1:16. We have to bring it down to that level, whatever the other titer may be. And it's not that 256 will come down more easily than 2048. It's very variable. So my final answer is that I would not go totally by the titers.
Right. Right. Thank you, Dr. Shaleen. I think that's one word which you said. I think that's very important as a message. Titer alone should not be the criteria, and I think that is a message from this issue one which we are discussing today. And just to highlight this point, this is Igawa. I mean, he's wonderful. He spoke in my last meeting which I did, and he actually spoke on ABOI, AMR in our immunotransplantation course, Hiroto Igawa, and he showed beautifully that if you have titer frailty, it of its own, it is not the deciding factor between somebody is going to have an AMR and somebody is not going to AMR. And it is important to have a titer which is lower down. But yes, in a situation when you don't have a choice, I mean, you just have to probably go ahead. Now, let me just now take the hepatologist perspective now and switching over to rituximab, because this is something which is now a cornerstone in management of ABO in transplantation. We know this is the drug which we are using. And so to understand about its use, its timing, its efficacy, there are many, many questions in this. But to start the ball rolling, I'll talk to Dr. Rakhi now actually. Rakhi, how do you think rituximab helps in preventing AMR? What is the basic mechanism which you think it acts, and how would you assess that?
Yeah, so the rituximab therapy has been tried in ABO incompatible transplants, and we know that there is a proportion of cells which are CD20 positive. So rituximab is kind of a chemical splenectomy. So if you're dealing with the lymphoid population, so we are targeting the CD20 set of B cells, which this drug can take care, and therefore it can prevent the subsequent AMR. Now the timing and the different protocols on dosing have been, again, what we have seen, which has been proposed by different experts and different centers, and the protocols that have been established. People have given rituximab varying from day 21 before the transplant, varying to up to 7 days also early on. So when we're dealing with the acute liver failure, so we can even give a little early on therapy. And this is shown by the Chinese people that it even works if it is given within the first 7 days of considering these patients for liver transplant. Now, the problem with rituximab is that obviously there is a risk of infections. And like you showed in your patient, and this is what we see when we see patients of acute and chronic liver failure, that we are dealing with the infections as a deadly component. Infections causes more rapid organ failures. So patient selection for ABO incompatible and giving rituximab is something which has to be very, very, so selecting out the right patients who are not florid infection, controlled infection, obviously when we've ruled out and controlled well, we can obviously give. So these are my thoughts.
Right. Absolutely right. I think I totally agree with you. Dr. Kaiser, the question which comes, which Rakhi actually just touched upon briefly, in a sick patient who has got possible sepsis, kidneys not functioning well, are you sort of a proponent of rituximab in such patient? Are you comfortable giving it?
No, I think it will be a difficult proposition giving rituximab in a patient who has had recent sepsis. So, this is like 3-organ failure, ACLF, almost 75% mortality. Even with transplant, these patients would have at least 30-40% mortality. So I think this is a difficult decision to whether to give a patient who has just recovered from sepsis, how many days you're going to wait after rituximab. Now, the other interesting thing is that these type of patients might already be on some sort of renal replacement therapy. They might be on CRRT or they might be on plasmapheresis. So sometimes you take a call whether you could give a low dose rituximab in these patients, combine it with like pre-transplant plasmapheresis to reduce the titers. So it depends upon a lot of factors on what is your final goal in these patients. Yeah.
Right. And maybe I mean anybody can take up this. The dose which we use in rituximab, we have center-based policy, which only 300 to 375 milligram. That's what we sort of use. Does it bother you? Would you like to change your dose in a sick patient? Maybe Shalin, you can answer this.
So this is again a question which we don't have clear-cut guidelines on. Actually, the topic that we have chosen, the type of patient that we've chosen, I think the reason is that we don't have guidelines what to do in such situations. So that's totally an apt question. But I would consider that if we are forced to do an ABN compatible in a sick patient, I would consider, besides, yes, I would definitely give rituximab. I would consider lowering the dose. So over the years, we have come to that, although initially the Japanese had cited a dose of 375 milligram per meter square, and that many centers have been following. But in our own experience over the years, we have reduced the dose for patients. And even in elective patients, stable patients, we have been giving 350 milligram a total dose. But yes, in such a sick patient, I would lower it even further. And the evidence that I'm giving is from my kidney colleagues, who in sick, like they are using a dose successfully of 250 milligram. So if I have to do an ABO incompatible in such a patient that we have just seen, I would lower the dose. Yes, we can give 200, 250. That is a matter of debate. And I don't know what would be the correct answer. But yes, the answer is I would use a lower dose. But I would definitely give rituximab if I'm forced to do a ABOI.
Right. I think that sort of answers the thing nicely. And just to emphasize about this issue of timing, because that is the most important problem in ACLF patient or ALF. We don't have enough time, and this was again shown by Gawa. Just to very briefly mention that guys who have no prophylaxis is one group. Late prophylaxis means that is less than 7 days before transplant, and early prophylaxis is more than 7 days before transplant. Giving of rituximab. These groups, when it was shown that the outcome of transplant actually was not too different. Actually, those who had no prophylaxis had an AMR of 29%, versus late prophylaxis had actually almost no AMR, and early prophylaxis only again no AMR. So what was concluded in this was that even late introduction of rituximab leads to B cell depletion to an adequate amount, and a reduction in the periportal edema and necrosis. So even in ACLF patients, one can give rituximab. Whether you give the full dose or, as we have just discussed, a modified dose, that probably is your choice. And I think yes, a modified dose would be my call as well. One thing I would like to ask to my now this I just showed a slide to because see, we are very hesitant in ABOI and ALF and ACLF. Let's be very honest, and we rarely can count patients like in single digits. But if you see literature, you'll find that especially from the Chinese and the Korean literature, you'll find this ALF and ACLF, ALF, ACLF. In all these small case series, you'll find there are actually these patients. Again here ALF, ACLF. So they are being done in other parts of the especially the South Asian countries, but we honestly don't feel comfortable. And they have been very nicely demonstrated that even in late prophylaxis group, once you give rituximab, your titers actually fall down pretty well. And that is the important thing which we need to consider. So you have to be really brave. I don't know, but it's just something which we are not comfortable. Just a word on plasma exchange. Dr. Raki, you are too much involved in plasma exchange in your ICU patients. Otherwise, I'm sure you do that exchange therapy for ACLF patients in any case. So you comfortable in like doing plasma exchanges patients who are going for ACLF, and if you have to do ABO and compatible transplant. So are you comfortable in doing a plasmapheresis in such a patient who's sick and perhaps septic? What is your thought on that?
So I would say that for ACLF and acute liver failure patients, for acute liver failure, we've seen plasma exchange even improving outcomes. So how we do it, our unit is that when we start these patients on plasma exchange, assessing the suitability of the patient, also for plasma exchange and florid infection patients where they are already into organ failures, we do not do plasma exchange in acute on chronic liver failure. So for that set of patients, a patient selection, but in acute liver failure, we do on early therapy, initial hemodynamic stabilization, and subsequently we start working up for the donor. Now, if the donor, for instance, by 24 hours or 48 hours, we see that you're trying to contemplate a ABO incompatible. This is where we've seen that even sometimes our titers after plasma exchange, we see that they're very much conducive with they're not very high. And in 1 or 2 patients, we have done just without giving rituximab, IVIG or anything, just plasma exchange.
So have you done ABOI transplants
yes, sir. Recently we did a patient, we had done 4 sessions of plasma exchange. It was a drug-induced liver injury who had a acute on chronic liver failure. So it was not purely acute liver failure. And this patient had undergone 4 sessions of plasma exchange. And the titers were around 1:64. And we did not give any other therapy. And we had taken that patient up for a liver.
How much time did you have between your intervention and transplant?
We had 6 days or so, 5 to 6 days. 4 sessions were given to that patient, sir.
Right. So that's it. Very good. So we have, this is building up experience in India, I would say. And anybody, the type of FLS exchange you do, we have the antibody selective or cytosol. Any particular thought on that? Anybody?
Yes, sir. So if I would say that between the 2 therapies, plasma exchange and the cytosorb or the heme adsorption, so we have our own experience in septic patients where there are lung issues or where there is some shock. There we see that plasma exchange is associated with more complications. So in particularly that set of patients where there is also some infection, we see that cytokine heme adsorption therapies are much more safer and much more better. And we replace the plasma because the bleeding complications may still occur with these systems. So we do replace fresh frozen plasma, but we do not do the complete exchange procedure like plasma exchange.
Great. Thank you so much. So this is, I think we're all aware of this. And just to mention that, people are doing this is a series of 10 patients who had ALF and they underwent an ABOI incompatible liver transplant. So it is being done, we have to be just, sometimes brave and take it up, but it's there possible. And as a techniques you've mentioned, Raki, I would agree with you. It's a standard technique, and probably the ABO selective immunoabsorption assay probably may be a little more desirable. But I'll come to my next issue actually. Yeah. So there would be a group of patients who are suboptimally desensitized. So they have not really, achieved what you would like to achieve before their transplant. So Dr. Kaiser, maybe have your thoughts. So if you have to, in a situation, take up a patient of, ACLF or maybe or ALF, who has not really been achieving the proper protocol of plasma exchange or rituximab, titers are high. So how would you proceed in such a patient? Would you give up?
I would not have any great personal experience on this type of patient, but what appears from the overall review of literature and the overall situation is that this is what we need to see, that if you have a suboptimally desensitized patient, either the titers were high or you do not want to give rituximab or you're using a low dose rituximab, then probably you start them on IVIG. And some people actually start IVIG few days before transplant, like 2 or 3 days before transplant, and then run it for at least 5 days or 7 days after transplant. So definitely IVIG is much more safer if you say, of course it has got some pulmonary complications, but otherwise it's much more safer than subjecting these patients to very high dose of rituximab or rather sometimes subjecting them to pre-transplant immunosuppression. Like some people would put them on pre-transplant mycophenolate or tacrolimus. So we have to see that we have many modalities, but the unfortunate thing is that every center uses its own protocol. Just now Raki was mentioning about the immunoadsorption. I think there's a Swedish center which has a protocol of only using immunoadsorption in this setting and not plasmapheresis, because they feel that with plasmapheresis the rebound of antibody is much more. And there are trials which now look at only rituximab and rituximab with plasmapheresis. The rebound sometimes is much more when you do plasmapheresis. I don't know the exact mechanism, but with only rituximab and other techniques, let's say IVIG, the rebound is less of the antibody.
Right. Thank you. I think that's very useful input. I just quickly, get to this. This is a very interesting thing. IVIG, we know it's a good agent to block the Fc receptors on mononuclear cells and nucleus alloantibodies. But just look at this study from Hangzhou in China, 101 acute liver failure patients, retrospective analysis, compatible transplant 66, incompatible 35 ABO incompatible out of these 101 ALF patients. They all receive single dose of rituximab on day of transplant and IVIG subsequently for next 10 days. And they have quadruple immunosuppression, basiliximab, corticosteroids, tacrolimus, and mycophenolate. And see what happens to these patients. Interestingly, the survival at 3 years, 86% incompatible versus 83% incompatible. The AMR rate, 2 out of these 35 actually had AMR who had incompatible transplant, which is 5.7%. Amazing. And the protocol, you can look at this. They give IVIG on day of transplant, rituximab, and then they continue to IVIG for the next 10 days. And what message these guys give from their study, we may or may not agree or we may disagree completely. But what is mentioned is that pre-transplant antibody titer would not matter. Average titer at transplant was 1:192. We would not really do in such titer in a standard transplant, ABO incompatible. This was decreased to less than 1:16 by day 1. And rituximab, a single dose at transplant, was efficacious and would continue its effect for next 3 months. I think this is amazing data, and I think this is something as an eye-opener for me at least, because 35 ABO incompatible ALF is something very, very exciting. Now I'll come to some issues which probably my surgical colleagues would like to add. Amit, would you like to add into these? When you're doing a transplant ABO incompatible, you are doing somebody who's like not well desensitized. So what precautions as a surgeon would you take? Any role of splenectomy? I mean, would you do anything extra in these patients? Do or not do? With a fear of, or with the concern of this antibody and anti-react stuff happening later on?
We have done 29 ABO incompatible so far, but none of them have been for ALF or ACLF in a situation which you have said. So for the cases where you can prepare well, I think there is no role for any of these. No role for splenectomy because you give rituximab.
Yeah. This is not, we are talking hypothetically as a situation where you are not prepared them well. Yeah, that's what I'm talking about.
For elective, there is no role. For ALF or ACLF, we have discussed many times that supposing if we have to do, what should we do? So the 2 or 3 things that we have made out is that we would give rituximab in all the cases as soon as it is decided that the patient is for transplant, even if it gives us only 2 days or 3 days. That is the practical situation. So it will give us maybe 2 days or 1 day or 3 days. It will not give us week or more than a week. But we would not go into a protocol where rituximab is not given. So we would give rituximab, and then we are also thinking of giving immunosuppression a day prior start, and then we would give IVIG, plasmapheresis as the condition permit, and we would do splenectomy. So this is our thought for situations where we would, if we are forced to do ALF or ACLF, we would do splenectomy. For portal vein infusion and hepatic artery infusion, I think these were the therapies which came in initially. There was some benefit, and then there were confounding reports. There were a lot of technical issues also. So I don't think there would be a role of these things in current scenario, even for elective or for non-elective. But splenectomy for ALF or ACLF, if we have to do, we will do it.
Right, thanks. Shalin, anything different would you do in the operative arena, in the intraoperative, postoperative period for your sick patients, ALF who are going for ABOI? Dr. Shalin, are you around? Right.
Yeah, can you hear me? Am I audible?
Yeah. I just was asking you. I just had a view from Dr. Amit. And so when you're operating on ACLF, ABOI,
I got the
anything
question. I got the question. So a few points I would like to make here. One is regarding whether we'll do plasmapheresis or immunoadsorption and or only give rituximab, as was being discussed with Dr. Kesar. So I think the goal is to get the antibody titers low.
No, and that part, yeah, that we agree. I'm telling you from surgical perspective, like splenectomy or not, like that.
See, we have not done splenectomy in any of our ABO incompatible for the sake of reducing the titers or making it safe. We would definitely give rituximab even if we have to operate the next day, and we would try to squeeze in a session of plasmapheresis or immunoadsorption to bring down the titers. In any case, in all of our patients, and that is 100% on day 1 and day 2, irrespective of the preoperative titers, the titers on day 1 and 2 are 1:2 or 1:4 at max. So probably the new liver is acting as a sponge. It's absorbing the antibodies, and gradually when it gets saturated, then the antibodies start rising. So I think it is very safe that we do give rituximab and then do plasmapheresis, whatever we have to do post-operatively. But I would not do splenectomy or in these infusion therapies. In my opinion, it only adds to the infectious complications, which we are already wary of. So I would not do any of these things. I would follow the standard protocol.
Right.
And and I won't give basically basiliximab either, what the Chinese had given, because that would add to the infectious risk.
And IVIG?
See, again, the question of IVIG, we used to use a lot of IVIG in the past, but we have totally given up. There are two reasons. One, we didn't find any benefit. Secondly, IVIG role is very doubtful. There are so many mechanisms of action that have been described in literature, but there is no one single thing whether it works or not. There's no clear-cut evidence. So we have stopped using IVIG. And second, most importantly, if you're giving IVIG daily, then you cannot do plasmapheresis, because then you will be just washing out this expensive medicine from the patient's system. We depend more on this pheresis therapy after rituximab and manage the patients for rising titers in post-op with pheresis rather than IVIG.
Right. I think that's very, very interesting input. So we have almost come to the end of this, very, very exciting topic. And any last minute input from the panelists? So after this discussion which we had today, as a message to the audience, would you go with an ABO incompatible in your next ACLF patient if you have to do it? I think.
Yes. Can I answer that question?
Yes or no?
Yes.
Yes, thanks.
Yes, if I've exhausted all other options.
Yeah, exhausted, yeah. So you are yes, Amit, yes or no?
Not still so sure. And maybe chance of this thing, we've now been pushed to the wall, but I would still, I'm not very sure about it. Of the concept. But yeah, but I'll say.
Right. Rakhi, what about you?
Yes, sir. I will surely consider in wherever,
Right.
like you
Dr.
said,
Kaiser,
in a very
Dr. Kaiser?
carefully selected group of patients. Yes,
Yes, that is all done. We are, and Dr. Kaiser, how about you?
Yeah, I think we should start considering these patients. We all need more experience with ABO incompatible transplant. Most centers, I mean, we have done very few. We've done hardly 5 in our process.
So I think we have almost 3 to 4 out of 4 yeses today. So I think that this is a very interesting panel discussion which I have done today, because I have been doing a lot of panels, but this was most educative for me as well. Something which we know about it, but we don't do because of our own fears. And maybe something like that comes up next time. We probably will be more educated and more, you can say, challenge taking. Our experience should come. And yes, perhaps. Because we are doing LDLTs and we will face this situation day in and day out, and donor issue will always be there. So I think with an educated mind, clear concepts, good counseling to the patient and family, I think maybe there's something which we can take up. So thank you very much. I would thank the organizers for inviting us for this panel discussion, and I think with my sincere thanks to all the panelists for the very useful comments and suggestions. I'll hand it over to the organizers for the panel. Thank you.
Thank you very much.
Thank you.
Thank you, Dr. Sehgal. Thank you for such
Thank you, Dr. Sehgal.
moderation of such an interesting topic. And we'll move on to the next session. And that is a very interesting topic. And we, in the transplant factory, we usually come across this problem not that frequently, but we do. And the topic of the panel discussion is early graft dysfunction, a Pandora box. And for this panel discussion, we have Dr. Joy Verghese to moderate the session. Dr. Joy Verghese is a director of hepatology and transplant hepatology at Glengals Global Health City, Chennai. And he will be joined with the esteemed panelists, Dr. Neeraj Saraf. He is Director Hepatology, Gastroenterology, Institute of Digestive and Hepatobiliary Sciences, Medanta, Gurugram. Dr. Shekhar Kubal, he is a Surgical Director, Liver Transplant, Senior Director, Living Donor Liver Transplant, Indiana University Health, United States. Then we have Dr. Matthew Jacob. He is a Senior Consultant in Liver Transplantation and Hepatobiliary Surgery, Aster Integrated Liver Care Program, Aster Medicity Kochi. And Dr. Charles, he is a Consultant Hepatology and Liver Transplantation at Aster Integrated Liver Care, Aster Medicity Kochi, Kerala. And Dr. Dinesh Jyotimani, he is a Director Hepatology, the Hepatology Medical Gastroenterology in Dr. Rela Institute and Medical Center, Chennai. Over to you, Dr. Joy Burgess.
Yeah, thank you. Thank you so much. Good evening to all. It's a pleasure to be with all of you. And my sincere thanks to the Fortis team, Dr. Vivek Raj and all the organizing members for this AILBS, the third international conference. So we will move on to the topic. It's a Mr. K. It's a 45 years old gentleman. He presented, it's a real case scenario. HBV related end-stage liver disease, child C, MELD was 26. Apart from the other decompensation, he had the recurrent left hydrothorax, and one time he had a bacterial empyema also. Weight was 75, BMI 26, and his performance status was 70. The liver, the frailty index was 4.3, almost a pre-frail. And before the transplant, so 2 weeks prior, he admitted. I required the ICU admission, and he recovered. So we did a living donor liver transplant. The donor detail I wish to share. Wife was the donor, and age 44, BMI of 30.2, and when we did the LAI, it was +5. MR fat estimation, this was 9.9%, and MR elastography shows 2.5. It's a right lobe without hepatic vein, and the calculated remnant was 40. So the intro details, the graft, the recipient weight ratio was 0.98. So RHV with 2 V5 and 1 V8, that time they used the PTFE brand. And the reconstruction was the single outflow in the hepatic vein, and the portal vein, hepatic artery, bile duct was as usual routine. So this is the thing. So the portal pressure, the pre was the 16, and the post, the pre-perfusion was 13. We have not done any inflow modulation. The cold ischemic time was 104 minutes, and the warm ischemic time 38. There was no significant reperfusion injury. The peak lactate was 3.1 intraoperatively, end time of the surgery 2.5. Almost we used 6 units of PRBC. So the patient was initially well. The day 5th, it showed there is a cholestasis, and this is the graph. So I wish to ask, we have the panel, the surgical panel members are there, Dr. Matthew and Dr. Shekhar from USA. And Dr. Matthew, actually, if you look at the graph, so we know that I explained about the detail about the patients and the donor detail intraoperative events. What's your comment on it, actually?
Yeah, obviously, a post-op patient after about a week progressing to worsening cholestasis. I can't quite see the INR there, Joy. I think it's 1.9,
so
isn't it?
Yes, yeah.
Yeah, so 1.9 INR, so INR hasn't settled. So first, we obviously need to rule out the standard things. Any issue with any sepsis, any immunological issues, and of course, whether any of the outflows have got thrombosed off. So once we've ensured all of those aspects are in order, then what we worry about in such a patient is whether this graft is going into dysfunction, and with the current definition, it would fit into that.
Definition, can you say something about the when we can define how to say the early graft dysfunction, Dr. Matthew?
Okay, so we have, I don't know whether you have a slide there, Joy.
Yeah.
So we have various definitions starting from 2006 onwards, and as late as the one from AILBS, which I feel is much more practical and useful thing. By and large, it centers around bilirubin at day 7, as well as INR more than being 1.5, 1.6 around day 7. While all the other definitions use a static measurement at day 7, the one described by Dr. Pamecha and all describes the same parameters with the jaundice, with the bilirubin more than 10 and INR more than 1.6, along with the high urea for 5 consecutive days after post-op day 7. The rationale being this is a dynamic thing, and if it persists, then you can call it early allograft dysfunction. And they've shown that this definition has got a higher specificity and sensitivity. So this particular patient would fall into that if you use the above criteria other than the ones defined by PMH.
Dr. Shekhar Kumar, actually, if you go through that, this almost shows the definition of the after LDLT, as you are doing in Indiana University, both the DDLT and the LDLT. So what about your comment about any difference in the EAD definition in the DDLT or LDLT?
Yeah, thank you for this question. It's actually interesting that, these definitions from the perspective of DDLT, you will see a lot of early allograft dysfunction. So, for instance, we use a lot of DCD grafts, and it's quite common that by any of these definitions, more than 50% of the DCD transplants will qualify EAD. And so EAD in DDLT is about 30 to 50% transplants, depending on how aggressive your organ selection is. So I think these are two different things from LDLT and DDLT perspective. I believe in LDLT, if you have EAD by definition, that would be from in a well selected graft, so there could be real problems such as small pore size and so on. But in DDLT, most of the times you'll get away with EAD if you just follow the definition, and only a small percentage will end up in primary non-function, which in my opinion is the real problem.
Okay, thank you. Thanks so much. And if you look into that, the EAD, the early allogram, so there are the four components will play a major role. One is the recipient condition, second, the graft quality volume, third is the technical issues, and the sepsis and issues. Dr. Charles, actually, can you say a few words? I mean, the recipient condition, in what are the recipient condition, we can predict that particular individual after liver transplant will go ahead for the EAD.
Thank you, Dr. Joy. And when you talk about recipient risk factors in EAD, one is the advanced age. The second would be the frailty of sarcopenia in recipients, frail and sarcopenic recipients. And third would be a bilirubin, INR, and creatinine that is captured by the MELD. So patients with very high MELD are likely to have a higher risk for EAD. And then the urgency of transplant, the emergency transplants, and presence of acidosis at the time of transplant, and very sick patients in ICU. These are the patients who are likely to develop EAD in post-transplant. So that would be the recipient risk factors, and then there would be the donor risk factors that contribute to the EAD.
The high MELD and the frailty.
High MELD, frail, sarcopenic, higher age, very sick patients in prolonged ICU stay, presence of severe acidosis at the time of transplant. All this contributes to EAD, risk of EAD in patients, recipients.
So this I wish to ask the question again to Dr. Shekhar Kumar. So when I gone through the literature in Cleveland, they are doing the HVPG before LDLT to all the patients, and based on the HVPG, they published the paper also. They are predicting the early allograft dysfunction in the Cleveland University. This is the paper they published. It showed they divided the pre-op just before the liver transplant in all LDLT, the HVPG less than 16 and more than 16. So that interestingly showed even the graft dysfunction, whatever after the liver transplant, the portal flow modulation, whatever they say. So can you make a comment about any idea about the usage of HVPG before the liver transplant to predict the EAD?
Sure. It's like intuitively you would imagine patients with a lot of portal hypertension will have hyperflow situation in a graft. So and more chances of small pore size. But you guys in India have more experience in LDLT as well as centers in other centers in Asia. of doing living donor transplants with smaller grafts with GRWR even less than 0.7 or 0.6 even. I think the Cleveland practice, as I know the surgeons there, what they do is they have very low threshold to do splenectomy when they have situations like this, such as portal hypertension, to optimize post-transplant outcomes. And with that, they're using a lot of left lobe grafts as well. So I think they have a different philosophy, and they want to have or avoid high pressure or high flow situations in living donor transplants. So I think there is more experience which perhaps doesn't agree with this from Asia and from India. So that's my thought. I don't know if my surgeon colleague agrees with this.
Any other comment about, this idea about the HVPG we can predict the early allograft dysfunction? Any panel members, any comment about it? Dr. Matthew?
HVPG is probably the reflection of the severity of the liver disease, isn't it? So obviously for a sicker patients, the HVPG is going to be higher. So particularly if they're in ACLF, particularly if they've had a septic thing, obviously the portal pressure is going to increase, the liver function will be in all over the place. So obviously those patients are likely to have HVPG higher than 16. You would expect them to have a high HVPG. And also doing an invasive procedure.
Dinesh, we can't hear you well.
Yeah, voice is not good. Can you loud, please?
Something happened. Also, can you hear me?
Yeah, please.
Yeah, I'm just saying, doing a HVPG in a patient, one who's sick, it may not be practically possible in all patients all the time, because they're going through the ACLF, and also HVPG will be higher in patients who are sick, who are in ICU, who had a septic episode. So obviously they are likely to develop early graft dysfunction, as what Dr. Charles said. So how HVPG can determine, it's obvious that HVPG will determine, but is there anything extra it's going to add? Actually, I'm not sure.
Yeah. So actually, this paper, so what our understanding of the physiology of the HVPG, if the HVPG is high, it reflects indirectly the portal pressure and the sinusoidal hypertension. Once we removed the sick liver and the implanted new liver, as we are hoping that it will be a normal, so it will carry away the normal portal flow and the normal portal flow pressure and the hepatic artery. But if you look into the graft, even after that liver transplantation, after the implantation, still the hepatic artery flow, it is not, discordant with that based on that HVPG pressure. So they are making comment about it whenever the HVPG is high. So that you still have modify the hemodynamics in the recipients. So that's why the text following that, there are the other researches are going on for the reducing the HVPG, the drugs wise, whether it is helping or not in the EAD. So Dr. Matthew, I'm coming to the second point. So the graft quality and volume. So what about your take on call to assess that?
Like you had briefly alluded to, what causes early allograft dysfunction is the key. Now, it is not particularly the size of the graft or in itself. Now, obviously, you're subjecting a particular graft to a higher pressure, higher flow situation, or hyperperfusion situation. That is what causes the shear forces in the sinusoids and causes the damage. There's an excellent paper coming up in Transplantation, which was put up in the group by Dr. Neerav and from his group, where they talk about the hyperperfusion index, which I found it quite interesting. Obviously, it is a lot of calculation behind that, and I've not read the full paper. But he makes a point of calculating the portal pressure intraoperatively, which I guess it's almost the same as your HVPG preoperatively, and then also looking at the splenic volume and the liver graft ratio, and then predicting which all patients might end up with an early allograft dysfunction, which is then used that particular value. I forget. I think it's you get a number of 9.9 based on that calculation. And if it's you get that number, and then you can predict and do to prevent. The HVPG is coming from trying to understand how high the pressure is, and also to help decide what to do intraoperatively, whether to modulate at all. But I think a better thing would be to calculate the hyperperfusion index and calculate the spleen size ratio preoperatively, and then go in with the knowledge that you have to do one thing or other.
I'm coming to the slide later on. Thank you, Dr. Matthew. So, what about any technical issues? I mean, Dr. Shekhar Kubal, how you will tackle the patients if you are on table?
So, I'll talk about DDLT situation, which is kind of more of our practice. Intraoperative situation, if you look at the risk factors for EAD or primary non-function, are prolonged cold ischemic time, as well as prolonged warm ischemic time. You want to select patients that and graft appropriately. So I think the setup for EAD or even primary non-function is starts in the beginning with your selection of recipient and graft. In DDLT situation, it's mainly steatosis, age of the donor, and so you have a marginal organ. So you have to choose recipient that you can put in without much difficulty. If you select a recipient that has portal vein thrombosis or multiple previous operations, it's going to be a difficult hepatectomy. So you're adding on to cold ischemic time and perhaps warm ischemic time if you're having portal vein thrombosis, such issues. So I think a lot of this is really into planning. But once you have accepted an organ, once your patient is on the table, there is nothing really you can do, and you have to kind of keep going and try to do the best. I think in LDLT situation, portal flow modulation can be done in situations where you have hyperflow or hyperperfusion settings. You could do splenic artery ligation or splenectomy or hemicaval. You can divert portal flow into the IVC and things like that.
Okay, thank you. So there's a splenic artery ligation, splenectomy, and the partial portoconversion. These are all the, on table, they're taken the decision. And Dr. Dinesh, and suppose the treatment of, the management wise, any difference in there after the diagnosing EAD in immediate post-op?
Yes, Jai. So basically, once you have the diagnosis, once the patient fulfills the diagnosis of early allograft dysfunction, we need to go through the algorithm, why there is early allograft dysfunction, whether it's a recipient factor, donor factor, or is this technical, immunological, or infection causing all this. So we need to address that accordingly. For example, what we are dealing, maybe it is small for size or something like that. In that scenario, we need to make sure the patient is on appropriate antibiotics and they don't get into any sepsis. And in terms of reducing the portal pressure, we may have to start them on a bit of terlipressin. And if still we don't have an answer, then we may have to go for liver biopsy to see whether there is any infection or any rejection is a possibility. We shouldn't over immunosuppress them. At the same time, we should not under immunosuppress them. So I think everything should be very closely monitored, fluid management, optimizing renal function, everything should go in a sequence actually.
So what about the role of the liver supporting therapy? Are you doing there or any other centers? for the early allograft dysfunction?
Yeah, so what we do is therapeutic plasma exchange. If, say, for example, if this is small for size and if things are not settling despite of medical therapy, then we will go ahead with plasma exchange. And if we found that plasma exchange has really helped too in the post-operative day 3 actually, and subsequently it has helped patients to recover from the early allograft dysfunction, particularly in the LDLT setting actually. So yes, so this is in the absence of other causes like rejection or sepsis, where this is there is some cholestasis and the enzymes are increasing, particularly the bilirubin is going up. So that is a setting where we use a therapeutic plasma exchange.
Dr. M.I.C.E, your comments? So actually, there are some of the predictions. So these are the papers. So different form of the risk score models are available. And are we practicing in the? I mean, Dr. Shekhar, in what is your opinion? There are the predicting the different scoring model for the EAD.
Yeah, thank you. And again, as I said before, you already know in which patients you're kind of going to get EAD. You already have marginal situations, but from DDLT perspective, if you want to avoid those situations, then what will happen is you'll end up doing less transplants. So as I said, EAD by definition ranges from 30 to 50%, and in most instances it recovers. So we don't follow any of these models, but when we know that there is going to be a high risk of EAD, we try to optimize other conditions.
There are so many predicting models are available to assess the early allograft dysfunction, the scoring system. But in practice, at present, we are not using all the predicting models. And this is the paper actually, Dr. M.I.C.E, you pointed out regarding the hyperperfusion index. Dr. M.I.C.E? Okay. So this, I mean, from the Dr. Nirav Goyal. So they assessed that is way which patients might land up with the early allograft friction related. So the two scoring system, one is the splenic volume assessment, the recipient and the graft and the recipient, the things, and also the HPI modification. And this is a question about when we can consider the retransplantation after a patient with the EAD. Dr. Shekhar, your opinion?
Yes, so EAD, which is turning into primary non-function, I think you have to retransplant the patient before it's too late. But at the same time, you have to be cognizant of not pulling the trigger too early, because there is potential for that graft to recover by optimization, such as plasma exchange or buying time, or treating other issues like infection or rejection. So I think it's a clinical judgment. You have to see the trend in a DDLT setting. In our practice, what we have found is mental status, like presence of encephalopathy and coagulopathy, tend to be more of helpful than looking at just level of bilirubin and AST, ALT, for instance. We also use factor V levels as another marker of graft viability, because it's short. It has short half-life, and it's not affected by FFP and other manipulations. So I think if you have a patient that has, the biopsy shows damaged graft, necrosis, or ballooned hepatocytes, you have lab values that are really not improving, and the clinical situation doesn't look good, I think that would be the time for retransplantation.
So before to conclude, and it's the early allograft dysfunction wise, there are some of the fixed factors. Some of the things are modifiable. So we know there are the recipient factors, already told, the age, elderly age, high MELD, the frailty score shows the less than 4.3. And the same way the donor, if there is a donor age and the graft volume, these are all the fixed one. And the surgically, if there is a graft quality and the portal hypertension, that's why the HEPG plays, and the surgical comment, these are all fixed one, very difficult to modify. But at the same time, if we know the patient, it's some of the modifiable factors, by modifying this kind of the factors like a BMI in the donor, steatosis, we can easily modify by the strict advice and the diet chart, regular exercise. And the recipient side, if the patient has the sepsis, proper treatment, if the patient has the organ failure, so waiting for the recovery and the nutritional improvement, this the way we can modify the recipient, some of the factors to reduce the EAD. And the surgical side, so the blood loss, we can maximum, we can try. And there is the portal inflow modulations, the techniques. So if we fail, or almost the literature shows almost 5 times the higher mortality compared with the non-EAD. So any comments about, all the other panel members? Any more comments?
Yeah, I think it's a good point to improve patients' nutrition and mobility. So I think the frailty should be as less as possible when they go in for liver transplantation. Because particularly for our setup, Joy, where we do a lot of living donor transplantation, and again, so unlike the West, the liver volume is slightly on the lesser side. So we need to prepare the recipient to the best when they go into the surgery, actually.
So regarding the scoring system, so even though there are various scoring system and the various definitions for the EADs are available, but mostly the 7th day that on day onwards, the bilirubin and INR and the drain output. So based on that only all the definitions are going on. So thank you to all the panel members for their nice discussion. And once again, my thanks to the POTIs, all the organizers of the AILBS, the committee members. Thank you so much.
Thank you.
Thank you. Bye-bye.
Thank you, Dr. Joy, and all the esteemed panelists for putting up such a wonderful discussion. So with this, we will move on to our next panel discussion, which is titled Coagulation Management in Liver Transplant, Blood Products and Factor Concentration. And to moderate the session, I would like to invite Dr. Piyush Srivastava. Dr. Piyush Srivastava is the Senior Consultant and Head of the Department Liver Transplant, Anesthesia and Critical Care at Fortis Group of Hospitals, Delhi NCR. As a panelist, I would like to invite Dr. Aninita Mukherjee. Dr. Mukherjee is consultant in HPV and multi-organ transplantation anesthesiology at Apollo Hospitals, Bangalore. Dr. Sangeeta Shetty, she is the Senior Consultant Anesthesia and Critical Care at CLBS, Fortis Hospital, Mumbai. And Dr. Navneethan. Dr. Navneethan is Senior Consultant Anesthesia and Critical Care at Lakeshore, Kochi, India. Over to Dr. Piyush for continuing the session.
Thank you, Vishal. Good afternoon, everybody. So we'll be critically discussing the management of coagulopathy, blood products, and the factor concentrates. As we all know that the perioperative coagulation management in liver transplantation has been very controversial and challenging. So initially, we used to attempt to correct the coagulopathy by monitoring the laboratory values and giving them some plasmas, then giving the cryoprecipitate of platelets. After that, several pharmacological agents and the factor concentrates came into the picture with the different viscoelastic testing, monitoring came into the picture, and the management of coagulopathy has taken a different change. So here we'll critically discuss with the faculty, and we'll come to the conclusion that how we can make our own line of management for management of coagulopathy during the liver transplantation. So to start with, I have some ROTEM picture which we came across during our practice, and this is a ROTEM of a 37-year-old gentleman. He was ACLF grade 3, Eclipse C, ACLF score was 58. He had a recovering AKI, hypofibrinogenemia, INR of 4.6, platelet count of 37,000. And his 2D echo had no regional wall motion anomaly with the mild dilated left atrium with the PA pressure of 42, and IVC was pretty distended. The second patient, he was child C with the recovering AKI with the low fibrinogen level and ongoing fibrolysis. His INR was 2.6 with the platelet count of 37,000. He had a mildly dilated LA with the PA pressure of 46, and IVC was pretty distended, and he was planned for the combined liver kidney transplantation. And during the surgery, we can see the ROTEM picture of this patient, and he had a massive, severe hyperfibrinolysis in the extem and the fibtem, and when we did the aptem also shows the recovery that was proving the diagnosis of the ongoing hyperfibrinolysis. So this is another patient who has a EF of 35%, dilated LA with the TR with the PA pressure of 48, but the pulmonary vascular of 2.8, and RV was mildly dilated. So if we see all these three patients were coagulopathic, at the same time they were volume overloaded, or they didn't have any room to get administered some large volume in the form of plasma or cryoprecipitate. So now, Nathan, can you tell me that what are the limitations of conventional plasma or cryoprecipitate or platelet transfusion during liver transplantation, particularly when we would like to correct this kind of coagulopathy in such a compromised situation?
Yeah, good afternoon, everyone. Thank you, Piyush, for inviting us. Rightly said, as you have pointed out, the patients which you showed, all three patients had high MELD, ACLF grade 3, purely coagulopathic, and patients, all of these patients, I mean, most of the chronic liver disease patients which we have with high MELD, huge ascites, they will all be overloaded. And secondly, when you come on to a combined liver kidney transplant, where you have very less volume to play with, there also the choice of your plasma and plasma product becomes very critical in these patients. So apart from your patients, which you have told, there are certain patients, particularly all the ALF also I would consider in that category too. So all these ACLFs and grade 3 ACLF, grade 2 ACLFs will all fall into that category where the limitation to actually play with the intravascular volume is very limited to us.
Rightly said, Noritan. So Sangeeta, can you tell that why the plasma has gone out of the armamentarium of anesthesiologists in the recent time? Sangeeta, can you hear?
I'm just trying to, yeah. Thank you very much, Piyush, for the opportunity, and good evening to everybody. Please excuse the noise in the background. So yes, as rightly pointed out by Dr. Navneethan, these patients and most of our patients are volume overloaded. And the problem with FFP is that in order to increase the concentration of clotting factors, say to about 15 to 30%, the volume that you need is quite large. And that is one of the reasons why FFP has gone into disfavor, apart from the usual issues of trally, taco, and trim. And also the outcomes have shown to be much better without the use of FFP. In our unit, actually, over the past 3 years, we have got the use of FFP down to almost nil. ever since the use of PCC has been started. So that is my opinion regarding FFP.
Rightly said. Apart from these things, the plasma transfusion may be associated with some, kind of unwanted kind of immunoglobulins administration, then some inflammatory cytokines. Also, they can be disastrous to the patient. So yes, these are the certain reasons now, because the conventional plasma and cryo precipitate and platelet transfusion are actually not that much nowadays. And even the literature says that this was a literature published in the 2021, and where the author found that FFP transfusion in acute varicose hemorrhage is independently associated with the poor clinical outcome. Initially, we used to think that if the INR is high and we need to transfuse the FFP to correct the coagulopathy and we will save the patient, but unfortunately, we actually jeopardize the outcome. And this is recently published in the Current Opinion and Physiology, and where the author pointed that the white blood transfusion is actually not warranted, and the goal should be to give the right product at the right time in the right patient with the right indication, while limiting the unnecessary exposure to the improved safety and patient-centered outcome as a part of comprehensive pediatric patient blood management. So Anita, as Navneet and Sangeeta said, that yes, there are some issues with the plasma and cryo precipitate. So we have factor concentrates in the form of PCC and fibrinogen concentrate available in our country. So what are the variations and obstacles you see in the use of coagulation factor concentrate during the liver transplantation?
Good afternoon. Thank you, Piyush, for inviting me. So as it was pointed out regarding the cases that you showed us, definitely your patients were overloaded, and we didn't want to give more of blood products to them. And we have also seen in our centers that the risk of TRALI is very high, risk of thrombosis is very high when patients in large volume FFPs have been given. So even we have started moving out of the practice of giving FFPs to the patients. So the other options, of course, the volume that is given through cryo or platelets is definitely much lesser than what it is with FFP. So there is still a role that we use cryo and platelets in our center. But what are the obstacles with using of PCC factor 7A factors, other fibrinogen concentrates and all? One is a cost factor, Piyush. There's definitely a cost factor involved. I mean, to our patients, definitely there is.
Yes, we will definitely come to the cost.
Yeah,
so apart from the cost,
thing.
what kind of problem you face?
So there is the advantages, Piyush, are many more, because we are giving a smaller volume. There is no need of blood grouping in these patients. These products are not dependent on blood group. You can just reconstitute and give it to them. The thing, it depends, and giving this, but there is literature saying that there is a risk of thrombosis maybe more with a patient if you give PCC, though we have not come across any complication like that. Factor 7A definitely has been used only in patients when all the other things have been used previously. So what I see complications, one is to procure and keep it ready, unless it's an LDLT setting where we are ready with it. In our settings, we do a lot of DDLTs also. Yeah. The other thing is, the cost factor definitely is something which hinders us from
Arintak, we can't hear you. Can you hear Arintak? So I think some network issue. So Arinta rightly pointed out the problems with the coagulation factor concentrate during liver transplantation. But yes, these are the problem actually because of not that good understanding with the right dosing. Actually, whenever we see the thrombotic complication, it is we use when we use the factor concentrates in the higher doses. So if we use these factor concentrates in a recommended dose or little underdose, probably we actually get more benefits rather than the some adverse effects. So now, Nitin, based on your experience with the use of factor concentrates in LDLT at your unit, do you believe that they impact post-liver transplant outcomes, and how they impact?
Absolutely, I believe that. See, what we have found out that most of these patients, when we start off with, particularly in the dissection phase, in the early part of the surgery, when you start correcting these coagulopathies, you end up giving up less blood and blood products also. And these patients, when they are, your requirement of blood and blood products are very less, you tend to, go for fast tracking these patients, early extubation, on table extubation, and maybe fast tracking them out of the ICU as early as possible.
Yeah, you rightly said. Actually, when you do the ROTAM and the patient is bleeding, so when you want to correct something, because if ROTAM is warranting the administration correction of extem by FFP or PCC, so if you order the FFP, probably it will take an hour in the thawing and getting
absolutely,
from the
absolutely.
Yeah. So these factor concentrations are readily available in your hand, and you actually don't want to lose the golden time. So it is readily available, and you correct the coagulopathy immediately, and you can save correct the coagulopathy and prevent the further bleeding. So you rightly said. So Sangeeta, what are your views on the increased risk of thrombotic complication related to the use of factor concentrates in LDLT? Can you prevent it, or it is better as compared to the plasma transfusion?
So thrombosis is always a feared problem, and as you all know that because of the rebalanced hemostasis, you're really walking a very tight rope. Whether it is hepatic artery thrombosis or portal vein thrombosis. Literature is showing that these are extremely safe products to be used, and that they don't really increase the risk of thrombotic complications. But I think we are still really awaiting the large results of the large trials, I think the Proton trial, which would really guide us towards the safety of the use of these products. But by and large, they're extremely safe products is what we can see. I think even Kirshner et al. Had shown that the risk of thrombosis is quite low with these products.
So what is your opinion, Navneetan?
Absolutely, I agree with that. See, what we have seen is, we can talk about a small group of patients, small number of patients. We are lacking huge, large, monetary-centric trials. But having said that, as you do these patients on a case-by-case, and you see these patients when you manage them with these factors and the concentrates, you do feel, that these, even though the risk of thrombotic complications due to rebalanced hemostasis, whatever has been, I haven't come across a single thrombotic incident in our patients where I have used to correct the TEG, though I use TEG, not ROTEM, but still, one and the same thing. So when you correct these coagulopathies, I have seen with the patients who, in fact, I have used it in patients who had a portal vein thrombus where a thrombectomy was necessary. Obviously, you have to time your use of these factors and concentrates, particularly during the dissection phase and all this time when you can avoid more of transfusion and its complications. But having said that, despite lack of evidence, lack of large multicentric trials, I feel that there is not much risk of any, if you use it in a proper way, as you have told before also, maybe in a dose adjusted manner in a patient selected, very few selected patients where the risk of thrombotic complications versus the bleeding you have balanced out, then you can avoid these thrombotic complications altogether.
Rightly said, Navneetan. You pointed out the certain points. So actually, when this PCC came into the picture, it was actually for the warfarin reversal. And when then people started using PCC, the dosing was very high, and people used to use in the dose of 40 international units per kg. So in those situations, people actually developed the thrombosis. And these were the patients who were actually have some thrombogenic tendency. That's why they were on the warfarin. And another reason for getting the thrombotic complication is a repetition of these factor concentrates, like particularly with the PCC. If you repeat the dose, so the chances of thrombogenicity is little high, because the effect of the PCC is actually standardized to the availability of factor 9 into it. But when you repeat the dose, the concentration of factor 2 and factor 10 goes up, and it increases the thrombin generation and leads to the thrombogenic complication in the patients, particularly who receives the PCC. Even in our study, where we used the PCC, and in the study of 60 patients, we didn't find even a single patient who developed the thrombogenic complication, and we concluded that the administration of PCC is pretty safe and as comparable to the plasma and other plasma administration. So, Ananta, based on your experience, factor concentrates would positively impact post-transplant outcomes in which subgroup of the liver transplant candidates? Can we give these factor concentrates as a blanket to all the patients coming for the liver transplant, or you have certain patient population? Anita, can you hear? I think some network issue. Sangeeta, you can answer this question.
Yeah, so you always have to be very careful, especially if you're dealing with patients with NASH or with HCC or any form of cholestatic liver disease, and anything that can really increase the inflammation, if you can say. So you, as far as you're being cautious, you're using the algorithms that have been put down by Klaus Gorlinger. I think otherwise you should be quite fine, apart from keeping these few points in mind.
So, Anita, what is your take on this question? I think you need to unmute yourself. So, Nauritan, what's your view on this question?
I agree. I mean, with Sangeeta also. See, certain group of patients definitely, you would like to avoid, and certain group of patients. I don't know about pediatric liver transplant. I haven't had much experience in using this in pediatric liver transplant, but I have used it in other transplants. Kidney transplants in pediatric patients, this factor concentrates. And particularly these subgroup of patients, you can avoid thrombotic complications. And when you look at patients like what you showed in the initial part of the discussion, like those ACLF grade 2, grade 3, ALF with very high coagulopathy, very bad TEG, with severe hypofibrinogenemia and fibrinolysis happening. In these patients, I think if you add these factors and factor concentrates, you will definitely help in the outcome of these patients.
Yeah, you rightly said. So we all know that the volume always remains issue in the patients undergoing for the liver transplantation. Because now the indication and candidacy of liver transplant patients are going up, and more high-risk patients are coming to us for the liver transplantation, like patient of the cardiac disease or the patient who have a kidney problem. Patients of the hyponatremia, even in hyponatremic patient, you won't like to get her sodium level corrected very fast because of certain issue of developing CPM. So even in those patients, like if the patient of hyponatremia is coagulopathic and you are giving plasma, you are giving 4-5 plasma, so probably you will lead to very rapid jump into the sodium level, which none of us will like. So in these particular situations, the PCC and fibrinogen concentrates plays a very crucial role to correct the coagulopathy, at the same time controlling the sodium level in the patient. And the patients who have not heart failure, in fact, the low ejection fraction, patients of the portopulmonary hypertension, where even a marginal increase of the fluid level can lead to the elevation in the PA pressure, and that can negatively impact the outcome after the transplant. So these are the certain patient population where you can use the PCC or fibrinogen concentrates, and you can actually improve the outcome after the transplantation. So as I said before, that rapid diagnosis of coagulopathy is very critical, and to appropriate treatment for the perioperative bleeding. And we all know that the time is life in severe bleeding. So whenever you see the coagulopathy and there is a bleeding, you need to correct the coagulopathy. You need to correct the coagulopathy as early as possible. So now coming to your point, Anandita, how do you justify the increased cost involved with the use of factor concentrate during the liver transplantation compared to the FFP and Cryo Precipitate? I think some problem with your...
Here's some issue, yeah. So Piyush, I'd just like to make a comment that, there is always this a question about the cost. So if you really look at yes, they are costly, and definitely compared to, in fact, the blood products, they are costlier. So this question will always arise as to whether it is justified. But if you look at the larger picture, and then you talk about this cost, I think it is very, very, very well justified, because these patients, like Dr. Navneethan said, can really be fast-tracked. We can extubate them on the table. The cost of the morbidity due to the blood product transfusion and the ICU stay may be much more than the actual cost of the products, if the concentrates, if you look at it. So I would say that you have to look at the broader picture, and you just see the beauty of using these products. The patients do so very well. So they're definitely justified, I would say.
Yeah, rightly said, Sangeeta. Navneethan?
Yeah, I absolutely agree with that. See, the cost, definitely it is much higher as compared to your cost of an, say, for a bag of FFP, which contains 350 to 400 mLs. But imagine 500 international units of PCC. That is equivalent to, say, 5 bags of fresh frozen plasma, isn't it? So when you look at correcting these patients, say if you end up using, as per the dose, maybe 2000 international units, 4 vials of prothrombin complex concentrates, and imagine the amount of fresh frozen plasma and cryoprecipitate you would have ended up using it. And the other advantage, which I feel, is the constant level of your prothrombin, the constant level of factors which you are giving to correct these coagulopathies, which is not consistent with your fresh frozen plasma and cryoprecipitate. The other thing is, when you see the larger picture, as Dr. Sangeeta has told, definitely, patients who have got a lot of transfusions, lot of products, you end up increasing the ICU duration, increasing the ventilatory duration in the ICU. So if you add up those costs, I would definitely say it balances out, isn't it?
Yeah, rightly said, Navneethan. Very rightly.
I think even the patient blood management, the principle of patient blood management really stresses on this, that these products the concentrates need to be used, and they can reduce, in fact, the cost of the patient posted for a liver transplant procedure. So
exactly. Now there's the literature on it also. Anita, can you speak? Can you hear us now? Are you using earphone, or we can't hear you? Sangeeta and Navneet rightly said that yes, if we use these factors of PCC judiciously in a particular subset of the patient and with the particular indications, so probably we will definitely come over the problem of the cost. Because if the patients who is already very sick, the patients who is ACLF 3 or ACLF-C, and we are giving lots of plasma and Graft Precipitate, who is already volume overloaded, who has already a kind of borderline chest issue, and we are already, he has already some infective predisposing factors, and we are giving more and more fluid to the patient. Probably he will have more ventilatory dependency post-operative. Probably he will develop more infection. Probably he will require more antibiotic upgradation and antifungal escalation. So if we see the corollary, I think so. If in these particular populations, probably the administration of PCC and fibrinogen concentrates, are very useful, and they justify the cost involved during the management of the coagulopathy. So thank you very much, Navneet and Sangeeta. And unfortunately, we couldn't get the opinion of Ananta because of some technical issues. And here, these panelists provided a fantastic points to the to the use of the PCC and fibrinogen concentrates in the during the management of the coagulopathy. Thank you very much. Thank you, Sangeeta. Thank you, Navneet. And thanks, Ananta. Thank you very much.
Thank you. Pleasure. Yeah.
Thank you all. Thank you, Piyush.
Thank you, Piyush, and thanks to all the panelists, Dr. Sangeeta, Dr. Navneet, and Dr. Anindita, for that wonderful panel discussion. We move ahead with our session. Next is a lecture on 3D virtual reality and 3D printing as a tool for surgical planning. And to present, we have Dr. Ziri Fronek, who is an associate professor of surgery at the Institute for Clinical and Experimental Medicine, IKEM, in the Transplant Surgical Department at Prague, in the Czech Republic. And we have as chairpersons Dr. Sonal Asthana, who is the clinical lead HPB and multi-organ transplant at the Aster Groups of Hospitals, Bangalore. Dr. Vidip Chaudhary, Senior Director and HOD, Department of HPB and Liver Transplantation, BLK M.I.C.E. Super Specialty Hospital, New Delhi. And Dr. Alfred Cow, who is the Senior Consultant, Division of HPB Surgery at the NUS, and the Senior Consultant in the Liver Transplant Program at the National University Center for Organ Transplantation. And Dr. Kumar Palaniappan, who is the clinical lead at the LAP Liver Surgery Department and Abdominal Trauma Liver Transplantation at the Rela Institute and Liver Medical Center, Chennai. Over to you, Dr. Ziri, for the talk. We'll wait for Dr. Ziri to join. He's not joined yet.
Hello.
Yeah, we have.
So, can you see me and hear me now?
Yes, we can.
Okay, hello. I wasn't a panelist. I joined you guys a long time ago, but only as a participant. So I'll share my talk and start with my presentation. Can you see my presentation?
Yes, we do. Please go ahead.
Okay. So the topic is 3D virtual reality and 3D printing as tool for surgical planning. We started use it for kidney transplantation like 10 years ago, then later on for liver resections and liver transplantation. and for planning the surgery, and later on for students, even the patients, colleagues, and of course we plan some future steps on that field. I come from Prague. Not many know our center, so just to show you, we do about 500 plus transplants every year. Of those, 300 plus kidneys, 160 livers, and all the other transplants as well, including uterus and small bowel. And on top of that, we do about 300 plus HPB procedures, abdominal and vascular surgery at my department. So the start was really 3D printing for kidney purposes, and the original idea started in 2012, where we established the kidney pair donation, the national program for the whole country. And later on, we even joined with Austria and Israel. So what we post to the recipient surgeon with regards to the details of the kidney anatomy is the CT angio, but also the 3D kidney model. And at some point I realized there are too many kidney models in my office, so I didn't really know what to do with those. So I decided to give them as a gift to the donor at the end of the hospital stay, when they go home and really being discharged from the hospital 2 days after surgery. So they get their copy of the kidney which they donated for transplantation. Now to the liver field. Again, the original idea came up in 2013, where we established the split liver program in our center, where nowadays about a quarter of the transplants we do every year is a split liver deceased donor. And of course, together with the time pressure at the DBD setup, we aim to understand the anatomy in a very detail. But what we figured out that the 3D print is perfect, and I'll show you pictures of that. The anatomy is very clear from that, but it is very slow. So in a setup of the DBD split liver, you have not enough time to do the 3D print of the liver and to understand the very detail of the anatomy. So therefore, we started working on the 3D virtual reality, which we clinically use since 2020. We developed our own software, where as a backup, just to prove that all is accurate, we use M.I.C.E, and you all know about the M.I.C.E, I suppose. We are really in a close contact with the company of M.I.C.E. They will even come next Monday personally to Prague to plan some of the future developments of the modeling, really. And but we use the commercial 3D virtual reality headset you can buy in a shop for like games, which is like I'd say $1,000, probably cheaper now. So the tools we have now for liver surgery and transplantation is CT angiogram, MRI, 3D printing, and the 3D virtual reality. When I was planning this talk, I realized how much data and pictures we have. So I just thought, and we are planning now shortly a paper, which is nearly written now, with the clinical use experience we have. So I decided to show you 5 examples where we use the 3D virtual reality for the liver surgery, including transplantation. Liver assessment prior to resection or liver transplantation with regards to the MDT and decision making. These are the pictures already sort of screenshot from the virtual reality, where you can choose the colors for the portal vein, for the IVC, and also for the tumor lesions. And this is a small child with hemangiomatosis of the liver, where we initially thought of extensive right resection, including AILBS, but then we realized that the tumors go further to the left. And if we compare that with the MRI or the CT, the 3D VR shows basically more, it's more visible on that, the extent of the liver tumors, where like on this picture on the right hand side, you can see the lesions go too far. This is another example of the tumors where we use the virtual reality to show both the size of the tumor and also the how far that goes to the appropriate vessels, and based on that you decide in what extent you can do the liver resection, or whether you'd prefer to do auxiliary transplant or AILBS or even liver transplantation as it is. Another example is pediatric liver resection, where our department is the only one performing extensive liver surgery for Czech and Slovak Republic together, which is like 15 million inhabitants. So all the liver large tumors get referred to us. So in 2019, we decided to, this is one example. This is a central liver resection in an 8-month-old child. This is another example that is pediatric AILBS, 6-month-old child. These are all either HCC or hepatoblastomas. This is the second stage AILBS week after the first stage in a small child. And this is the virtual reality in use, where if you look at the CT, and that's bring to the attention the first benefit, if you look at the CT or MRI and you magnify the picture on your screen, what you lose is the sharpness. You lose the sharpness, there's more shadow coming, and the border between the tumor and the vessels and the rest of the tissue is not really sharp and clear. The good thing with the virtual reality is both that first of all, that you can combine on one picture the bile ducts and the vascularity, and B, if you magnify the picture, you do not lose the sharpness. It all sort of transfers, it calculates, and you still have got the really sharp picture in front of you. This is the picture from the theater, where there's 3 surgeons, one of those myself, the one with the headset, and we used to have one headset only, and the screen on top of that to show to the people around what I'm looking at and what I'm trying to show. You can basically grab the piece of the liver, you can magnify that to a huge piece, to a huge size, and then you have like a desk with which you can cut it in pieces or look into it and to look at the very detail. And of course, you can measure the distances either between the tumor and the vessels, or length or diameter of the vessel as well. This is the original setup, where at that point we did not, this is 2020, we did not have at that point the chance to join the 2 headsets. Now we can join maximum 5 headsets. So because if you look at the screen, you can see only a little part of the detail, and far more detail is in the headset. So it was a bit difficult to share the very detail. This is another step. So there were already 2 headsets possible to be joined, and the screen on top of that, as you can see left up, it's sort of a pre-op room assessment room, where we used to have the screen. Now we have it really in theater on the wall, as you will see later on. Another example is auxiliary liver graft, which after removal we used recently for domino liver transplantation. And this is a very special setup where it's difficult with the conventional imaging to see basically on one screen 2 livers, the one which needs to be replaced and the one which will be removed from the original recipient and transplanted to the next one. So this is basically one picture of the virtual reality, where on right hand side of the screen it is a native liver. This was originally an Echinococcus recipient who's had very small segment 2 and 3. And the Echinococcus also involved the inferior vena cava. So I decided to give him a split liver segment 2 and 3 from deceased donor, together with the inferior vena cava segment, which I replaced, where I replaced the original one, which was being swallowed by the Echinococcus. And this is 6 months down the line, where both the native liver and the graft has grown a bit. So now we decided to remove the graft, excluding the IVC, of course, which needs to be kept in place, and stop the immunosuppression for the recipient, because he doesn't need that anymore after that. So this is another picture of virtual reality, where you can already see the vessels and the branches, that based on that you can plan where you will cut your portal vein and the original left hepatic vein, which in this situation looks like right hepatic vein. This is the picture from the back again, and you can measure your distances and turn that. And this is what it looks like if you put on the headset. So you can basically go through both the graphs, so you can turn it the way you want it, you can measure the distances, magnify that, and really decide where to go with your surgery. This is the picture from the theater where you can, well, now we have really on the big screen on the wall what we wish to have. And those are either print screens from the virtual reality, or you can, through Wi-Fi, join the virtual reality itself, or you can put, of course, MRI and CT and other pictures there. So this is the case of the domino. So the intra-op, on right-hand side, you can see the native liver. On left-hand side, there is this graft. Oops.
Dr. Feri, we cannot hear you.
Can you hear me now?
Yes, you are audible now. Yeah.
Sorry for that. Somehow got interrupted. Can you hear me now and see me?
Yes, of course.
Okay,
Please.
sorry for that. And this is another example of the same. And this is already the recipient plus the domino donor. So the recipient was a fulminant liver failure patient with Wilson's disease who received split liver left lobe, but
So your slides are not visible.
Oh, why is that? Can you see them now?
Yeah, now we're good.
Sorry, it got interrupted somehow. So this is a slide which shows sort of two pictures in one. So this is already the recipient's first transplant, which was a fulminant liver failure, Wilson's disease, who received left lobe from full right split liver. But that was ABO incompatible. And unfortunately, a week after the transplant, she developed over 1,000 anti-A antibodies, although she was blood group O. And we have never really seen that in our experience, but that's it. So therefore, she developed severe humoral rejection of the graft. So there's the green one. And behind that, there is this left, originally left lobe, now auxiliary liver transplant graft. So you can put those in one picture and sort of measure the sizes and measure the differences and whether there will be enough room for the next graft for transplantation. 3 is the 3D print use. Actually, for the elective cases, we still use it, not for the acute ones because of time, but you can do like this is the Echinococcus large tumor, where the Echinococcus cyst involved vast majority of the liver and partly swallowed also wall of the IVC. And in this case, you basically delete the tissue except the Echinococcus, but keep the future liver remnant volume, which is segment 2 and 3. And again, you can look at the vasculature in a very detail and decide where to resect and what to preserve. This is the same thing in theater already. So you can look at the model and which is 1-in-1 and then compare with the resected liver, of course. And this is the case, extended right resection, hilum preserving for the large Echinococcus. This is another example of that, and this is the liver live donor right lobe, where you can either print the whole liver, which is of course not very interesting print, but you can print like the left lobe with the vasculature of right lobe, or right lobe with the vasculature of left lobe, plus of course the bile ducts. And based on that, you can both see the anatomy and plan your surgery. But B, as on the kidney side, the left and right lobe receive the donor and the recipient in a nice box as a present when they go home after the surgery. And this is the situation now with the 3 headsets, and these are the printouts from the headset, where you can choose one particular view of the liver once you play with that and save it as print screen, and then you put it for your surgery on the screen, and you can really look at that during your surgery. So these are the measurement. This is the look at the portal vein and hilum branching. Here you can see that we had. Can you see my mice or not?
Yes, it's visible.
Okay, so here you can see that we went for the right-sided graft without hepatic vein. So here we clearly seen, and we could have measured how far will be the 2 branches of our segment 5, but with 1 ostium, and upwards 2 branches of segment 8. Down left 2 posterior inferior branches for the right lobe. In mid down is the bile duct branching. Behind that, the portal vein with segment 1 branch, which we wanted to preserve, and so on. So you can really choose the pictures you wish to share. And this is again the scenario from the theater, where you could put on the screen the pictures you wish to see during your surgery, and you can anytime come back to that and keep thinking of what you're doing. And this is the video, a short video, one of the last slides, which really shows you. I hope it will run. Is it moving?
Yes, it is.
Okay, so here you can see how with your handset, these are the 2 livers. On the left-hand side is the old first graft, which will be removed. On right-hand side, there is this auxiliary liver graft with a native liver. You can put like that 2 on the screen or in the headset next to each other. You can turn them, you can twist them, and this is the tool you use for basically inside vision of the liver. So you sort of go through it like that. The deeper you go, the deeper you see. You can look at the native or the first transplant. You can look at the graft. You can highlight with your hand or with your finger what you wish to show to your colleagues or to the students. And so this is really the way you use it. The good thing with that is Wi-Fi connected, is anonymized, so you can take it with you home and keep working it from home. You can work from distance. So I've got now connections, or I keep working for years with Leuven in Belgium and with Bologna. So my colleagues over there have got their headsets, so we can do virtual MDT really, so we can see each other, not the faces, but what we are doing in the virtual reality. So we can do sort of multidisciplinary team on distance from any part of the world with international really participants. So that's the next step, I'd say. So what benefits that brings comparing to CT and MRI? It joins, as like MEVIS, MRI and CT in one view. With the magnifications, you don't lose the sharpness and the detail. You can put 2 or even more livers in one picture and compare the sizes, compare the volumes. And that can be used like for these unusual cases like auxiliary graft to be used secondhand for another recipient, I'd say. The current use for us in Prague is the Deciton split liver. We can do this within an hour if you have got the 3D, the data from the CT and MRI. There's of course differences. We have got special protocol for the CT and MRI. You need 0.75 millimeter thickness of the layers to get the very detail in the virtual reality. But those are always in the machine. You have just make sure that you get them from the machine before the technician will do the conventional CT or MRI pictures with thicker layers. We use them for live donor liver program, for liver resections, adult and pediatrics, and for live donor kidney programs I've shown you. And there will be future steps, as I said, MDT use international. There is not really yet a tool for segmentation, like if we wish to do monosegment resection or monosegment split liver and reduction for a very small child, and volumetry. We wish to compare in more detail, like the liver size recipient who has got already CT at the time of listing versus the graft volume. We can do now 5 users, but hope for more. And of course, we use it for teaching of both colleagues and medical students. And my special thanks to our IT guys, Petr Raška and David Shidrina, who are really great guys. They really managed to develop our own software, which is getting even further developed over the time, and Darina Supalova, who is the consultant radiologist in our department, and who really helps with that a lot. And I thank you for your attention, and I'm ready for your questions.
Okay. Thank you so much, Dr. Fronek. I really enjoyed that talk. This is Dr. Sonal Asthana. Yeah, so we've done a few 3D prints for pediatric liver transplant using an STL file from a CT alone, and I mean it is particularly helpful. And you've pointed out very clearly that it isn't something that can be used in the short term because it takes a lot of planning to do and it takes time. So VR is one way forward, but clearly the problem is certainly with the images being static, So my question was, do you do any MIS or robotic work as well? Because there are certain, sort of VR models that are being developed, which will allow onlay of the RHV and the MHV while you're doing a resection close to them. I mean, do you think that is something that would be, where this is headed eventually? Because so far we are making good models and it's interesting and of course, helpful in certain cases. But when we are talking about utility, it probably would be better if we are able to access those images real time while we are operating. So, I mean, basically it's a 2-stage question. One is where are the limits of this technology in open operations? And secondly, do you have any experience if we utilize them in, say, robotic surgery?
Thank you for both questions. Robotic surgery, we don't have yet, but it's coming. So we hope to start with the robotic shortly. And of course, the use of the imaging sort of visible into your op field is one of the possibilities. We've tried something similar in our animal lab. A quarter of our hospital is experimental, so there's big animal labs in that. So we tried some stuff. So far, I never had a feeling that it really helps. I always felt that really it more interferes with the surgery rather than helps, to be honest with you. And with experience of both laparoscopy, like I've done over 700 kidney donors, so you know how deep you go and you expect where your vascular structures are. I'm not sure really whether I need it in my op field. Right. But having that in theater and being able to interrupt the surgery anytime and go back to what I've shown on the screen, having your pictures or even the virtual read, you can unscrub, put your headset on and go through that again and measure your distances. I found that helpful, especially like in the cases pediatric liver resections, where sometimes a millimeter, 2 or 3 can be a big difference and can make a big difference. So there, the magnification, but not losing the sharpness, in my view, is very important. And B, in those cases which are very unusual, like the domino auxiliary, where actually you have, no matter what experience you have with the anatomy and branching, in this case, you have no idea what is what and where it goes. So
Yes.
there you can sort of extrapolate the measured distances on the virtual reality versus your upfield. And there I felt comfortable having that, really.
It's excellent work. I look forward to reading your paper. Thank you so much.
Thank you. Thank you.
Hi, Jerry. Nice to see you, Alfred from Singapore. Thanks for the nice presentation. I have perhaps 2 questions to ask you, because I think using image and enhanced guidance for hepatobiliary surgery is really going to be becoming the gold standard for many of us now. The question is, how do you factor in the cost effectively? And how useful is that additional cost to our surgical planning, which most of us really think that cost is something that's worth investing. But I just want to follow up. The next question with Sonal is actually that have you explored other technology that currently now that is already able to incorporate a real-time image superimposition during surgery for open and laparoscopic? Because there are some of them around now, and I think that probably to me is probably the next phase to move on to. Yeah.
Thank you again for both the questions. Well, the cost, that's one of the things I'm struggling to write in the paper, really, because so far it was our grant money we invested and we keep spending for that. It's even difficult to calculate the cost of the service, because so far we have got sort of a couple of years of investments into the software, which is basically IT guys' time, surgical time, radiology time, and so on. Therefore, that's one of the reasons why we will have a personal meeting with the M.I.C.E people, because we wish to know how these guys manage to calculate the price for each case. Because for now, it's only us using this service. But of course, like after this talk, one of you guys may ask to send me your 1.75 millimeter data from your CT and make a model for you. I'd be more than happy to do it as an example, but if you ask me for 10 cases, we will struggle, of course. So once we sort of open the door for other centers and other people being interested in that, we have to figure out a price, because there will be people dealing with that. I'll come back to you with the sort of open discussion how we manage to calculate this price. And of course, there will be, the only way will be probably, because we are state-led hospital, we can't charge anyone for anything. The only way will be probably a private company dealing with that, to whom we will sell it. And like for life, we'll have the service for us for free, but the company will start charging for the service, as like M.I.C.E, I suppose. I don't know how they manage, but we'll probably copy their history. And B, same question or similar question to the previous, having the view of the VR in your upfield might be an option, but we didn't come to a stage where I felt it is helpful, really, because you have got your loops for your surgery. So putting a headset on top of that, see through that something, I found so far very difficult even to imagine. Changing the headset with the virtual reality is not helpful, really. That means that's time-consuming scrubbing, unscrubbing. Having also, there might be an option having an extra camera which will sort of print into your upfield some of the figures. but we are not quite there yet. But that might be, or I hope it will be, one of the developments of the software to deal with that for those who will be interested. So far, and of course, I wish to go in steps. You know, it took us to 10 years to move from the kidney to the liver side, really, to gain some experience and feel comfortable with the outcomes. That's why we have as a backup the MEVIS. Make sure it's accurate, make sure it's true what we are seeing, you know, and the measurements are right. I think we need a bit of time, or myself at least, and our unit, to get comfortable with the system we have got now in place. But there will be, of course, future steps, you know, into what you meant.
In this case, if you don't mind, I just wanted to share with you, you can consider exploring mixed reality technology now, which is available. And in fact, we have used HoloLens mixed reality in liver surgery for both donor and complex hepatobiliary surgery. Just like how MAVIS is done, basically converting patients' fine cut CT scans into 3D models that are now converted into holograms. And this hologram actually can be projected onto the surgical fields using the HoloLens. The difficulty that has not been overcome, what Jiri said quite rightly, is actually the wearing of loops. But if you use it during laparoscopic surgery, it's not a problem at all because we're not wearing loops for that. So to me, I think that quite quickly will become the reality in the near future. In fact, it is already here. Yeah, we're just seeing more adoptions in the future.
And I'll be more than happy if we can develop that, guys, together with someone.
Yeah. So you know, if I have a chance to meet you personally, I'll show you how it looks like. Yeah.
Okay. Thank you all.
Dr. Krish had a question.
Thank you, Izzy. It's Krish Menon from King's College Hospital. Fascinating talk.
Hi.
And I'm just going to lead on what Alfred talked about. And we're just about embarking in collaboration with the Royal Free Hospital on a laparoscopic approach to this problem. And it's basically, I can't disclose the name of it. It's just going to go through the process of feasibility. But it's exactly that, where you overlay the image on top of your laparoscopic 3D camera system and allows you to then navigate the vessels a bit better. It's a feasibility study that we're just about to start in summer this year. So it's a fascinating area and really loved your talk. Thank you very much.
Thank you.
Just a comment mainly.
Thank you.
Okay, I think if there are no questions, then we can move on to the next session. Thank you, Dr. Jerry, for putting up such a fascinating concept, and to all the chairpersons for taking their precious time for us and our audience. Thank you so much. So with this, we would like to move on to the next session, which is a panel discussion on minimally invasive donor hepatectomy troubleshooting. And to moderate the session, I would like to invite Professor Sudhindran, who actually needs no introduction, but for the inverse, he is a clinical professor and chief transplant surgeon at Amrita Institute of Medical Sciences, Kochi, India. And for the session, I would like to invite the panelist, Dr. Vivek Vij. Dr. Vij is the chairman and chief transplant surgeon at AILBS Fortis Group of Hospitals, Delhi, NCR. Dr. Fabrizio Benedetto, who is the professor of surgery at University of Modena and Reggio Emilia, Modena, Italy. Dr. Krish Menon. Dr. Krish Menon is consultant surgeon, liver transplant and HPV at King's College University Hospital, London. He is the clinical lead at liver transplant surgery, King's College Hospital, and vice president and president-elect of the British Transplantation Society, and president-elect of Great Britain chapter of the IHPBA. And the last panelist is Professor Kim. Professor Kim is director of Asan Liver Center, chairman-elect of the Korean Association of HPB Surgery at Asan Medical Center and Ulsan University, Seoul, Republic of Korea. So to start the session, I would like Dr. Sudhindran to take up the next.
Thank you very much. Can you hear me?
Yes. Yes, Sudhi.
Thank you.
Yes,
you can see the slides as well, right? So as we all know, the donor hepatectomy, the minimally invasive way, is taking over most units now. it's initially been started by people like Dr. Kim in Korea, but it's very attractive for everyone because the donor is somebody who is undergoing the surgery for somebody else. And therefore, we need to keep the donor morbidity to a minimum. And we all know that the huge big scar that the donor has will and often does lead to long-term morbidity. So here, the panelists, we have some of the experts in the world, both in laparoscopic as well as robotic surgeries. So without further ado, let me just get on to the team. So my first question is it the first slide? Can we go to the previous slide now? Yeah. Let me ask my first question to Krish. Krish, the equipment for laparoscopic donor hepatectomy or laparoscopic hepatectomy, is that different from any other advanced laparoscopic surgery? I mean, do we need any of these stuff? With your vast experience, what do you think are the essentials for a laparoscopic hepatectomy?
I think most of the things you've highlighted there are essentials. So 3D camera system, I personally prefer it to the EndoEye, which is a 2D system. You can go for the robotic system, but I think if you're talking about laparoscopic, 3D camera is, I believe, preferred to the EndoEye. The ICG camera is useful in certain scenarios where you want to actually be absolutely certain in terms of negative staining. CUSA, I think, is an essential. I don't use harmonic oil ligature, as you probably know. For years, I've been talking about a different instrument I use, which is called the Lotus. So energy devices, you need a energy device. It doesn't matter which one you use, it's what you're used to. It doesn't matter whether it's a harmonic ligature or a Lotus. But out of the list that you provided there, I would use a 3D camera system, a CUSA energy device, and ICG camera.
Thank you, Krish. Dr. Kim, what is your views on this? What are the essential absolute must for a laparoscopic donor hepatectomy?
So yes, and thank you for your kind invitation. So I will explain my experience. I usually use 2D camera, so rigid type with 30 degree, and ICG fluorograph and laparoscope CUSA. So so I think that, and I don't have any 3D camera a lot, but then so I actually personally, and I don't feel any any need to use it. And regarding the CUSA, 2 or 3 years ago, there was the international survey about laparoscope donor hepatectomy. At there, most surgeons preferred laparoscope CUSA around 80%. I also prefer laparoscope CUSA, which is a very effective instrument for safe parenchymal transection. So I think then energy device often damage blood vessels and the risk of bleeding is higher than CUSA, I think.
So you don't use a 3D camera for your lap donor hepatectomies?
Yes. Only 2D camera.
Okay, fine. I think. All right, okay, thank you. Okay, thank you very much. Now, Vivek, what do you think are the most difficult bits of laparoscopic donor hepatectomy? Because you have done a huge number of open donors before you progress to lap, as most have. So which were the areas that you found most difficult to tackle?
I think so. I always put it in such a perspective that every case, every step is a bit different. You know, there are certain cases in which mobilization because of multiple inferior veins is difficult. In some cases, hilar dissection is difficult because arterial anatomy, biliary anatomy is very different. But most of the cases, you know, to prevent any donor complications or for a better donor outcome, I think I spend a lot of time in bile duct division. So that is where I say it's not difficult, but we have to spend time so that the outcomes, not only in donor, but recipients are also good. And secondly, in a kind of mobilization phase, sometimes we see IVCs which are very, from caudate to cranial side, they're very long, there are multiple short veins, and handling those veins sometimes becomes difficult. For me, these two are more important, and experience gaining in these two would definitely lead to less conversions.
What about transection? Did you find
not really
particularly losing the plane or the bleeding during transection?
Not really.
Not really. Okay.
Transaction is not a problem at all.
Dr. Kim, during mobilization, I mean, any tips in avoiding trauma? Because sometimes when you mobilize the liver and you move it around, etc., it can cause sometimes inadvertent lacerations. Any tips on how to do that? How to avoid that?
So well, and for experienced surgeons, liver mobilization and highlight dissection and bile duct division, so on are not very difficult. In my opinion, the volume of the liver is the biggest problem. The large volume of the liver makes it difficult to mobilize the liver. Moving and lifting a large liver can damage the liver parenchyma. So although not yet published, our multi-center and multivariate study found that larger volumes were associated with increased complication after Laplace donor hepatectomy. So a complication increased in case greater than 700 grams of liver parenchyma. So I think that the bigger the liver parenchyma, the higher the complication rate. So that's my opinion.
I couldn't agree more. I completely agree with that. So now coming to the robotic side, thank you for joining us, Dr. Di Benedetto, and you are an expert in robotic surgeries. What about robotic surgery? The problem is we are limited with the equipments because we have only the ones that the Da Vinci gives us. Do you miss some of these robotic, some of the equipments that you have access to in open or even laparoscopic surgery, like liver retractors or not being able to move the table, etc.? Dr. Benedetto?
Good afternoon. Yes, good afternoon. Good afternoon. Thank you for kind invitation. I think that the choice to approach a donor with robotic surgery is not based on the lack of certain instruments. For sure, CUSA allows a precise dissection and accurate isolation of the middle hepatic branch, like a V8 and V5 branch. But as you know, the robotic dissection can be implemented by the use of CUSA from the tableside surgeon. I'm not very confident with this kind of setup because it changes the paradigm of robotic resection. I prefer, in my opinion, the transection line to be guided by the consult surgeon. Retraction is not a big deal. We can apply percutaneous stitches usually and obtain a good view as well as additional trocar for the tableside surgeon.
Yeah, go on, please carry on.
Yeah, yes, about the table, it can be titled at any moment if you have the designated table for integration with Da Vinci Xi. I think it represents an important improvement compared to previous edition of the robot. You just have to stop a few seconds and start the one instrument, and you can keep the robot on all docket while moving the table.
You use that all? Do you use that? It's a very expensive edition, but do you have that? Yeah. You use that? Okay. What do you think is the most difficult step of robotic donor hepatitis compared to open or even?
I think that the most difficult step may be transition from cholangiogram-based identification of the bile duct as we do in open to the use of EGC enhancement bile duct identification. Of course, at the beginning of the experience, it may be a good option to select donor with a model anatomy, a small liver, as you know, Kim previously. Also, intraoperative management of V5 and V8 and posterior hepatic vein may be sometimes tricky at the beginning of the experience. However, they can be closed during transection and reconstruction at the end during bed table surgery.
Yeah, it's interesting. Initially, I missed the cholangiogram. But then subsequently, now that I've been using ICG cholangiogram all throughout, now in open, I'm missing the ICG when you do it, because when you do the ICG cholangiogram and divide the bile duct, you real time, you know exactly where you're cutting. But when you do a cholangiogram, you have the cholangiogram, but then when the actual moment of division, you don't know where you're cutting. So nowadays, sometimes I feel ICG is perhaps slightly better than an operative cholangiogram.
Totally agree. Totally agree.
So, Krish, when you progress from an open to a lap donor hepatectomy, I know you have not been that much in donor hepatectomies, but still, any hepatectomy, what do you think is the most important step? The problem with the liver surgeons is that they are so intensely involved with the liver, their experience with laparoscopy is not that good. And likewise, the advanced laparoscopic surgeons, the liver experience is not that good. So this marriage of two very, very advanced but disparate skill, is probably one of the most difficult steps. So what do you think is more important, the open hepatectomy experience or advanced laparoscopic experience, or both? Or what's your opinion?
I think, in my opinion, both are important. If you keep in mind that the donor for us is the most important person in the whole operation, because the donor is the one who cannot afford to have a risk or a complication. So if you're focusing on the donor, you need to be a surgeon who's got very good knowledge of liver surgery. So it doesn't matter whether it's been previously open and you've transitioned to laparoscopic. But equally, if you're going to do a laparoscopic donor hepatectomy, I think you have to have advanced laparoscopic liver skills, because as Kim pointed out, if you're an experienced laparoscopic liver surgeon, mobilization, hilar dissection, all of this is very straightforward because you'd have done that so many times. And then when you do it on the donor, again, when you're using, particularly if you're doing donors, most of them are within that 700, 800 grams, you are much more efficient in the way you manipulate your instruments and the way you operate. So I think you need both being a good liver surgeon and having advanced laparoscopic liver surgical skills, because hilar dissection doesn't come easily. When you do more and more livers, it becomes much more easy. The porta becomes easy. Everything is easy because you're not doing this for the first time. And donors you can't afford to take a risk with donors. So I think it's both that you need.
Dr. Kim, what do you think is the learning curve?
So I agree. One learning curve? Oh yes, then it's generally known that the appropriate number of cases for laparoscopic major hepatectomy is around 60 to 80 cases. I agree. However, if surgeons have a lot of experience with open hepatectomy, they can reduce the learning curve a lot. So in my case, a laparoscopic major hepatectomy was my 4th case, and the laparoscopic donor hepatectomy was my 8th case. So of course, at the time, I had more than 1,500 open hepatectomy. So the well-experienced surgeon can reduce the learning curve, I think.
Thank you. Dr. Benedetto, coming to robotic donor hepatectomy, do you think progressing from open to robotic is easier than open laparoscopic robotic, that curve? Or what do you think? Have you had a lot of experience in laparoscopic before you progress to robotic?
I think that previous experience in laparoscopic donor hepatectomy is not essential. However, it is crucial to have a laparoscopic background before moving to the robotic surgery. In general speaking, the learning curve cannot be completed without the help of a proctor. I think at the beginning, especially at the beginning of the experience, which is particularly effective in a dual console, is available. As reported in literature, about 30-35 cases are necessary to reduce operative time and get confident with the robotic liver resection, but over 50 are necessary to complete the learning curve for a major hepatectomies. Moreover, we should mention it that donor hepatectomy is much more complex than standard major hepatectomy, as you know. I think that experience with minimally invasive valves, for example, and perialar cholangiocarcinoma may be a good training thanks to the precise dissection and need for preservation vascular structures till the end of the liver split.
Thank you. Thank you. So, Krish, Dr. Kim and Vivek, I would like each of you to answer which are the patients that you will perhaps avoid a laparoscopic donor hepatectomy and go only for an open. Are there any such patients? Krish.
I think it's probably unfair for me to answer that question because, I think we are in the very infant stage of this procedure. I would say even then, what you keep is the same principles, which is to avoid taking on patients who you think have got comorbidities on board and are going to add to the risk of going through a donor hepatectomy. And that doesn't change whether it's a lap or an open donor hepatectomy. The risks are the same. So if you got somebody in terms of body mass index that you think is prohibitive, or you think that the right lobe is going to be too large, in addition to the other problems that the patient has with comorbidities, then you perhaps should think about strategies to modify that before you take them on or not do them. I think that's and again, I'm not in a position to give a strong answer on that.
Thank you. Dr. Kim, are there any patients where you'll say, no, I won't take it, I will do it open?
So to be honest, and although the operation time of laparoscopic donor hepatectomy takes longer than open donor hepatectomy, experienced surgeons can perform almost any donor hepatectomy. So however, I recommend that inexperienced surgeons who don't have a lot of experience perform the laparoscopic donor hepatectomy according to the original indication. I have already published a single long wall hepatic artery, portal vein, and bile duct, and the fewer right inferior hepatic vein, less than number 3, and the graft volume less than 700 gram of liver volume. So that was our reasonable indication. But I always say, so many experienced surgeons do almost any cases of donor hepatectomy, I think.
Thank you. Vivek?
Yeah, Sudhi, I agree with Kim. In initial experience, when we have very few cases, the experience is less, then we try to avoid certain difficult cases. Obviously, the large volumes, multiple hepatic veins, inferior hepatic veins, multiple bile ducts. But now, after achieving a good experience, right now we don't have any anatomical contraindications for laparoscopic liver donors. Right now, even we have taken out around 8 to 10 livers which are more than 1 kg livers. So I think it's all experience. With time, you learn how to maneuver and manipulate. And presently, we don't have any contraindications as such for laparoscopic donor hepatectomy.
Thank you. Dr. Benedetto, or robotic donor hepatectomy, anybody that you would now take on board?
Yes, I totally agree with the previous comments. I think contraindication to robot hepatectomy are the same as for laparoscopy. As I mentioned before, it depends also on the moment of the learning curve and proficiency acquired. I will recommend not to select multi-duct, especially at the beginning of the activity of the robot harvesting.
Thank you. So I think all the masters said exactly the same thing. That is, in the beginning, make sure you choose the good ones, like normal anatomy, not too heavy grafts, and not too sick recipient. But then as you progress, perhaps you shouldn't be able to take on everybody. Thank you so much. I think all the masters are thinking alike. One question I had was the use of hanging manure. It's maybe relatively easy in a laparoscopic surgery. In open, we all do it. I would like to start from the robotic surgeon. Dr. Benedetto, do you do hanging manure? Is it a must? Is it difficult? Any tips on how to do it?
Not always. Also, we should consider that the caudal view of minimally invasive hepatectomy allows a better control of the vena cava This is the reason why we usually don't use hanging in the robotic measure hepatectomy. Sometimes I just suspended the right hepatic vein for an easier access of a stapler, but usually we don't use the hanging in the robotic approach.
Thank you. I mean, I don't do either. Krish, I know that you do hanging maneuver almost always. Is that correct?
No, it's not correct. I don't use hanging maneuver at all.
All right.
I think I have tried it, but I haven't found any advantage. And I think one of the disadvantages is the hanging maneuver works well in an open situation where actually you're hanging something. But when you're doing a laparoscopic procedure, it's a bit more harder to perform the hanging maneuver as such. What you can do is you can pass the tape round, go through the hollow of the right vein where you made the tunnel and bring it out from the cable side. But to actually lift it and then hang it to get the effect of the hanging maneuver in a laparoscopic setting, I have found very difficult. So I've basically gone away from it now. I just do a standard approach. So
all right, okay. I couldn't agree more with that. Dr. Kim, what about you? Do you do hanging maneuver all the time?
So I think this maneuver depends on surgeon's preference. So actually, I don't think this is necessary. I don't use a hanging maneuver because a blind dissection between the hepatic parenchyma and vena cava, confined laparoscope space may increase the risk of bleeding due to damage to short hepatic vein. So yeah.
Correct. So I don't do either. I mean, Vivek, what about you? Do you do hanging maneuver?
I don't think it's necessary, but I think we should answer this question in a different way. For a major hepatectomy, which is not for a donor, I think it's not necessary at all. Not necessary. For donor hepatectomies, what we initially used to do was not completely free the cava. But now, for our last around 60 cases, we've started doing complete caval mobilization along with the hepatocaval ligament division at an early stage. And then we pass on the tube. But in one or two cases, yes, we didn't do that because there was, while passing the tube, there was some injury of right hepatic vein on the medial side, which we later on handled without passing the sling. It's not necessary, but it makes the things easier for donor as that's what we feel.
Thank you. So I think generally the most people don't do hanging, but some people do that. So it's an optional thing. Thank you.
Can I make a comment there, Sudhi?
Please, please.
I think it's, as Vivek says, I think it's making sure that you've got that plane when you've dissected the right hepatic vein and when you've done the caval branches. It's making sure that you've got that divisional plane correct. And sometimes, it's making that is correct rather than actually doing the hanging maneuver. And sometimes I pass a tube down, into that hollow just to make sure that the plane is correct. And that's all you need. You don't need to actually lift the liver.
You're right.
Thank you.
So
thank you so much, Chris. Thank you.
Just a small comment, not for the sake of its necessity or not. For donor hepatectomy, I consider it important and useful because it drastically reduces the warm ischemia time later. When you try to free the cava later after transaction, it becomes very difficult, and the warm ischemia time goes beyond a limit. So for that reason, we spend slightly more time initially to free the cava and pass the tube. That's the main purpose of our doing a hanging maneuver.
Yeah.
But freeing the cava we can do, before you transect the portal vein itself. Once you've transected the liver completely.
We find it slightly difficult after transaction.
All right. Okay.
No, I agree with Vivek there. Yeah.
So I think bleeding obviously is probably the most important reason for conversion or the commonest cause for conversion. Perhaps it may be easier to manage the robotic, but I would like to get the tips from the experts, starting with Dr. Benedetto, on how do you manage bleeding, particularly the middle hepatic bleeding or IVC bleeding. Any tips? Do you use any clamps or do you just go for things? Any anesthetic maneuvers that helps you? Dr. Benedetto?
Oh yes, depending of the entity of the bleeding. However, Pringer maneuver is always a good idea. It should be mentioned that with mini-invasive approach, also the bleeding is somehow magnified. So we should carefully evaluate the entity of the bleeding and pick the correct management. In general, it's recommended to convert before measure bleeding, or at least having controlled it with a clamp, with a vascular clamp, but no rush for conversion without having controlled the bleeding.
Thank you. Krish, I've seen you manage one major bleeding once. So
I think for me, when you're talking about bleeding, it's before you come to the theater. So how you trained your team, and it's all about preparation. When there is a bleed, if your team know exactly what needs to be done, it makes the job a lot more easier. So I think, simple things like, making sure you got needle holders ready. You make sure that you got your bulldog clamps ready, because I find sometimes using just a non-vascular kind of clamp just to close the vein, commonest bleeding you get is from the branches of the veins. It's very rare to get bleeding otherwise. And you can actually close it and place a bulldog, put a stitch. And for me, that's where 3D comes in. And perhaps in your robotic cases, you have the same advantage. There is no pass pointing, so you can do very precision suturing. I think the other thing that I find useful, I personally do not use high pressure pneumoperitoneum. I don't raise the pressure if there is bleeding, because I don't believe that's a natural way to treat bleeding. I would still control the bleeding with a forceps, occlusion type of forceps, and then wait till I've got control. And then you can use sometimes a bipolar to get, if it's a small bleed, you can do bipolar. If it's a major bleed, place a bulldog and then stitch it. But I think preparation is the key. Make sure your team know exactly what happens when there's bleeding, because more often than not, you don't want panic stations when there is a bleed. Just calmness in theater, deal with it as you would normally do.
Hurry slowly. Dr. Kim, your expert opinion on managing bleeding, please.
We know surgeons should do surgery without bleeding, which is very difficult. So prevent bleeding. So in my laparoscopic surgery, the CVP and intrathoracic pressure is reduced as much as possible, and Pringle maneuver is usually used. If bleeding occurs, and we increase the abdominal pressure sometimes, or apply gauze packing with some hemostatic materials. That's the same maneuver with open surgery.
Thank you. Vivek?
Yes, I think all the questions are being answered. Preparation, prevention, I think these are the very important parts of when we go for surgery, especially for any patient, but more for donor hepatectomy. Now, our way, although we are managing to suture some bleeding points, but I want to put forward few facts what we face during the surgery, donor hepatectomy. Now, it depends on bleeding is from where. If it is from the right side or left side, if we are taking out doing right donor hepatectomy and bleeding is from right side, then we manage it slightly differently from if the bleeding is from the remnant side. I say it because if we have to take out the right lobe of the liver, what we actually do, suppose there is a bleeding from a divided segment 5 vein or segment 8 vein. I don't suture it. I just put a piece of gauze there, press it, and wait for some time. It stops immediately, maybe 5 minutes, 2 minutes, 3 minutes, and then we proceed with the donor hepatectomy. Now, if it is on the left side, which is the remnant side, of course, we have to suture it, close it, clip it with whatever means we do. We don't increase the intra-abdominal pressure. First thing I do when there is a bleeding from veins is to put up a gauze there to avoid any air embolism. And of course, sound, my anesthetist, my surgeons, everything is ready on the back table, and then we proceed.
Thank you. So basically the tips from all the masters, apply pressure first, warn the anesthetist, perhaps decrease the central venous pressure, perhaps maybe increase abdominal pressure, and get your team ready, keep everything, get your needle holders, get your sutures, everything ready, and put stitch or clip or whatever is required, just like in open surgery, but be calm and be prepared for the whole thing. Thank you.
Can I make one comment, Sudhi?
No, I agree completely. Pressure is the most important thing, and patience, pressure and patience, and using a Pringle will be quite useful as well.
Can I make a small comment, Sudhi?
Please, Krish.
One of the things, I think we talk about managing bleeding during transaction, which is one aspect of it. I think when we finished, one of the things we've started to do routinely now is at the end of the hepatectomy, major hepatectomy, you just take the pressure down to 8, get the pneumoperitoneum down to 8. That will expose any small venous bleeding. So you get your hemostasis absolutely perfect before you close. It's just a small tip again.
Thank you. Thank you. I think our time is up, but this is the last question. Vivek, shall we finish with this last question?
Yeah, please go ahead.
How to reduce warm ischemia during retrieval. So I would like everybody to sort of just mention how they exactly go through the last bits of the hepatic artery, portal vein, hepatic vein, Makuchi, the order and what exactly they use. Dr. Benedetto, can we start with you, please?
Yes. Yes, preparing the endobag at the beginning of the procedures and place the liver inside the bag before stapling, if possible. Sometimes, obviously, this is very difficult, but this is a nice way.
Thank you. So put the bag inside first. Krish,
yes.
anything that you?
I don't have. I think I'll wait to see what the others
say. Okay. Dr. Kim, what is your actual? Can you give your thing in detail, please? What do you use for everything?
So actually, there's no special tip to reduce warm ischemic time. So if the dissection and transection can be done completely before procurement, there is no need to have any procedure. But if it's not, for example, if the mobilization of the liver is not completed, so anterior approach that hepatic artery and portal vein are cut first and complete liver parenchyma is done during procurement is recommended. So then please don't worry too much. The Pringle maneuver blocks the hepatic inflow for 15 minutes. Likewise, a warm ischemic time of around 15 minutes is not a big problem.
Thank you very much. I couldn't agree more. I think, again, the tip is hurry slowly. You obviously have to be prepared, but there's no point rushing at that particular time and then end up damaging your vital structures. Vivek, your final tip on reducing warm ischemia? And
I differ slightly. I differ slightly.
Reduce, yeah.
I think for a donor, warm ischemia time for a recipient matters. We should critically look into early graft dysfunctions and certain patients who don't recover after more than 10 to 12 minutes of warm ischemia time. Now, we have taken few steps to decrease warm ischemia time, and one step which has really changed our warm ischemia time is complete cable dissection at early stage. That's very important. We keep the liver hanging just by right hepatic vein, right portal vein, and the right hepatic artery. That's it. There's nothing. Secondly, of course, the tips like giving phalansteal incision, keeping everything ready, putting up the bag, those are the things. Keeping your staplers in place, knowing from which port the stapler goes, where it goes, is very important. And third thing we have changed is we bleed the liver out inside. We fire single-sided stapler on portal vein and then divide it free, so that the whatever liver after of course clamping the right hepatic vein, so whatever blood remains, warm blood remains inside the liver, drains out. Because sometimes what happens when we pull the liver out, there is a gap of around 1 to 2 minutes till the time we take it out. So with all these maneuvers, our average warm ischemia time is now less than 5 minutes, and majority of cases 3 to 4 minutes. It makes difference. That is my experience. We will publish about this, but that's how I differ from Professor Kim.
Thank you. But we've actually looked at our patients, 102 robotic with 100 open, and warm ischemia time in robotic sometimes it goes up to 15-20 minutes sometimes. Interestingly, the transaminases was actually lower in the robotic group, both the donors and the recipient, compared to the open group, where the warm ischemia was like 4 or 5 minutes. So I really don't know, Vivek. Maybe I think yes. So it's been very, very reassuring, and I think Dr. Kim is. So I am with Dr. Kim in this particular thing.
I think one of the things probably we can say is that when you're doing this, particularly in the early part, is to have a set sequence that you run through with your team before you start the actual divisions. And sometimes it sounds silly, but actually saying, okay, this is the artery, next stage is this, next stage is this. And I think what Fabrizio said about putting it in the endo bag before you actually start all this decreases the time, and then sometimes you don't want to rush through these things, as you said, hurry slowly.
Right.
So I think planning with your team is again important.
Very important.
Thank you, Krish. I think you have said it all. I think we have come to the end of our discussion. Any questions from participants? Anybody wants to make a comment?
Just wanted to thank Vivek and AILBS for the invitation. Yeah,
Thank you, Krish. And thank you, Vivek. Yeah.
Thanks, Abhi. Thanks, Professor Kim.
Nice to see you,
Thanks,
Kim.
Fabrizio.
Thanks, Fabrizio.
Thank you so much. Thank you.
Thank you so much. Bye-bye.
Bye.
Thank you.
Bye.
Thank you, Professor Sudhindran, and all
Thank
the
you.
esteemed panelists for their taking out their precious time. So with this, we move on to our next session.
The next session will be a case-based discussion on a pediatric liver transplantation. For that, I would like to invite Dr. Kausar M.I.C.E, who is a senior consultant liver transplant HPB surgeon at Fortis Hospital, Delhi NCR. She's going to present a case which we recently had in a pediatric case. I would like to also invite the esteemed panelist on this case, Dr. Manuel Rodriguez, who's a transplant hepatobiliary surgery. And he's a surgical director of pediatric liver transplantation at Primary Children's Hospital, Intermountain Healthcare. And he's also a medical director of Living Donor Liver Transplant Program at Intermountain Medical Center, Salt Lake City, Utah States. The next is Dr. Rohit Kohli. He's a very good personal friend and a renowned hepatologist and gastroenterologist. Dr. Kohli is the chief of gastroenterology, hepatology, and nutrition, and he's a director at the University of South California Keck School of Medicine and UC in Los Angeles, United States. And Dr. Naresh Shanmugam, who is a director of Women and Child Health and is a senior consultant pediatric gastroenterology hepatology at Dr. Rayla Institute of Medical Sciences, Chennai. So over to Dr. M.I.C.E now.
Hi, good evening. We begin with the pediatric case discussion. So a 10-month-old baby girl, blood group B positive, weighing 10 kgs. She was born of a non-consanguineous marriage at full term, normal delivery. Presented to us with complaint of jaundice since birth and clay-colored stools. She had an MRI for diagnosing in her native country, and she was diagnosed with extrahepatic biliary atresia. She has not undergone any Kasai or liver biopsy before she came to us. Her vaccination was done till date. So it was a straightforward case of biliary atresia. She underwent living donor liver transplantation on 9th June. Her donor was her father, 23 years old, same blood group. It was an open donor hepatectomy. We had a left lateral segment graft weighing 259 grams with a GRWR of about 2.6. The anastomosis was standard. The left hepatic vein was anastomosed by a triangulation method to the inferior vena cava at the LHV-MHV site. She had a portal vein which was anastomosed to the graft portal vein after doing a patch plasty to increase the portal vein diameter. And the graft artery was anastomosed to the right hepatic artery. The graft retrieved had 2 small ducts for which hepaticojejunostomy was done. Explant liver came back with biliary atresia with the hyperplastic lymph nodes, no gallbladder, no malignancies. So this was her post-op course during her stay. We started her on piperacillin, tazobactam, and metronidazole. She remained all right for the first 3 to 4 days. ET culture grew Klebsiella, but she was asymptomatic, so no upgradation of any antibiotics was done. She was started on valganciclovir as per our protocol from day 5 when a CMV sample was sent, which later came back to be positive. She started spiking fever from day 4, day 5. Urine culture was positive and antibiotics were upgraded accordingly. But her fever spikes did not settle down. She spiked fevers of 101, 102 with tachycardia going up to 180, 190, dull baby. At the time of spikes, we did withhold her immunosuppression, that is tacrolimus. She was on steroids and mycophenolate. She also had occasional clay-colored stools since post-op day 10 onwards. So we continued with modifying our antibiotics. Ultrasound Dopplers were fine. There was no IHBR dilatation on the Dopplers. Finally, we did an MRCP on post-op day 18. Although MRCP did not show a major ductal dilatation, there was some fluid in that area with just borderline ducts. We took her up for re-exploration the next day, during which we opened the Roux loop. We probed both the ducts were open. So we put in an internal-external stent for her, and at the same time, we came back with a liver biopsy. The liver biopsy showed TCMR with RAI of 5/9, and also a bit of necrosis in the perivenular areas. It was negative for C4D staining, CMV came back negative. So as soon as we got the biopsy report, she received a steroid pulse therapy. And she did not respond to that. She kept spiking fever. She kept having clay-colored stools.
So the next, the question is, how do you manage these patients in terms of immunosuppression, and you have sepsis and cholangitis in terms of the rejection? Dr. Kohli, can you comment on that, please?
No, sorry, can you hear me? This is Naresh Shanmugam. Before going into that question, could you please show us what was the AST and ALT levels from the start? Because there is a graph showing temperature, but actually we need to see what is the AST and ALT.
So this is a graph showing post-transplant levels of bilirubin and INR. INR was pretty much okay. It had recovered. Bilirubin started spiking at around post-op day 16, 17. And this is the enzyme trend. So you have SGOT, SGPT, SAP, and gamma GT. I hope you can make out.
I think the SGOT and SGPT were sort of high from day 6, day 7. Why the biopsy was not considered earlier?
So in pediatric cases, she in spiking 102 fever, one culture was positive. So we were thinking in terms of infection and sepsis, or rather cholangitis, keeping in mind that she had 2 small ducts.
Because I think this is a very important point, because whenever we go through history, I think we have been seeing case history presentation, and with the temperature, you stop the immunosuppression, and sometimes we miss a rejection, which can have spiking temperature. I think that's all my point. I think I'll pass on the whatever question to Rohit.
She got a left lateral segment, so there's always a congested segment, and there is a raise in AST ALT level on day 6, day 7. So that's a part of the reason also.
No, we do see a lot of children, and we do really around 8 to 10 transplants per month, and we see the enzymes going up high on day 2, day 3, and we see a trend of downward trend after all. I think it might take a while to settle. Some children settle day 15, some might take 21, but the trend is more important. But here the trend seems to be going down, and then the spikes going up.
Can you tell us a little bit about the immunosuppression she got from the get-go, and if you had tacrolimus levels? I know, sorry, Rohit, I know you have a question pending, but just I think it will help us to know kind of how the immunosuppression started and the levels at this part, because this is one of the big things. But I agree with Naresh. I think that there's something not very common with the pattern, and we do probably the same amount of whole livers and splits or live donors. Last year it was 50-50, and I don't think there's a big difference usually in the way we're seeing kind of the peak of the enzymes or the changes from one graft to the other. Obviously, there may be a little bit of an increase in AST and ALT in some of the technical variants, but I think it's important to know kind of when was immunosuppression started.
So, immunosuppression was started from the post-op day 1 itself, and it was continued. In fact, it was increased after the on post-op day 3. The immunosuppression was doubled. Her levels was around 4, so it was increased up, and that's when she started spiking fever. So that was one where we thought that maybe because there's been an increase in the immunosuppression, that's what is leading to, a spike in infection. Secondly, not a lot of immunosuppression was withheld, and whenever we did reduce the dose of pan-graft, she was supplemented with an additional dose of steroids, and she was always on mycophenolate. So
I want to know a little bit more, like Manuel was asking, what is your standard immunosuppression? Do you use induction? And if so, what do you use for induction?
generally, we do not give induction immunosuppression. We start with tacrolimus on post-op day 1, mycophenolate, and we have steroids. So steroids, we continue IV steroids in children for about 2 weeks, and that's when we start tapering it off. And pediatric, we target tacrolimus levels of around 8 to 10. So along with mycophenolate, which is dose-based.
Naresh, Manuel, do you use induction? We do. We use basiliximab here.
So our protocol is if they have increased risk for, or we're worried about potential renal failure. So for or if we have patients, teenagers with autoimmune diseases like PSC or autoimmune hepatitis, then we usually do induction IL-2 blockers and MMF. On a standard, just biliary atresia patient, we are just doing steroid taper, intraoperative bolus, then taper, and tacrolimus monotherapy. There are other cases like hepatoblastoma cases where we know that there's an increased risk for renal toxicity where we'll do IL-2 blockers. So if there's any concern for early renal function, we will do. And we use basiliximab. I know Pittsburgh uses Thymo, and this may be part of the discussion later. Naresh?
We don't use, as I said, if there is a renal impairment and we are anticipating some events, we do use, but it's only rarely we have been using. Steroids, we use IV 3 days and then change to oral, not high dose, just 2 milligram per kg and maximum of 20 milligram, and we don't even go more than 20 milligram. And then from day 3, we start tapering. We start tacrolimus day 1, and we try to maintain a level between around 10, and we don't start CellCept unless there is we are expecting some kidney issues like Alagille syndrome, PFIC, where we would run the tacrolimus slightly on the lower side, 6 to 7. In those cases, we add CellCept. Otherwise, we wouldn't add cells. It's one dual regime, and that's all we do.
So in your programs, maybe the comparison we can kind of try to understand is how much ACR in the first month do you tolerate? Given that you're not using basiliximab as much, looks like Delhi isn't, Manuel, you're not, Naresh, you're not. We're using pretty much 9 out of 10 cases, we're using basiliximab induction, but then we taper steroids pretty fast because of that. So we get, I would say, around 10 to 15%, not more than that, ACR in the first 30 days. I don't know how your numbers run.
Yeah, our numbers would be around 20% of ACR, because all the enzymes, we do a biopsy confirmation. None of them are treated just with the steroids. So all of them will have a confirmed biopsy before treating. So probably we are looking at around 20%.
For us, Rohit, it actually was a change in my practice because when I was at Yale, and Udemy Pro is part of the kind of the school that you guys have, we used to do IL-2 induction for all, and I was very used to it for over a decade. When I moved to Salt Lake City, Linda Book had this program with just steroids and monotherapy, no induction. And at the beginning, I wasn't very convinced, but I have to say the rate has been like that, probably less than 20%. We're very, just like Naresh said, we're very careful that if we don't get in the right levels and the enzymes are going the wrong way, we do a biopsy very fast. Like if there's a concern. The one thing I have to say I don't like, and we're still kind of going back and forward, and I think it's an important topic, is the level of tacrolimus, right? When I was in New Haven, again, we use IL-2 blockers, and then the levels were 8 to 10. And then here we use TAC monotherapy, no CellCept unless the cases like Naresh said, and And then, but the levels when I came were 12 to 14, and I was very worried because I was seeing a lot of EBVs and CMVs. So now it kind of convinced my team to be lower, but still 10 to 12. So it's like you choose your poison, right? You don't do IL-2. If you don't do basiliximab, it is a little bit less expensive, and you lose that. But on the other hand, then I think you're forced to use higher tacrolimus levels, and then you have other risks.
I think it's always a balancing act.
Back to the original question. So how do you manage the immunosuppression in this scenario? With the patients, has a diagnosis we don't have a biopsy in this case by that time. So so considering the clinical diagnosis of the rejection and what the ongoing the infection and sepsis. So how do you manage these patients?
Naresh, what are your standard antibiotics, and how long do you keep them on? To me, these seem a bit aggressive.
Our standard antibiotics is monotherapy with piperacillin tazobactam, and we give for 5 days, and we are thinking to downgrade to 3 days. Probably looking at this scenario, probably day 3, day 4, when spiking temperatures, we can't find a reason. Obviously, we have to rule out any perforation, which is quite common. But this child did not have a Kasai surgery before, so it's unlikely to have a perforation. And in the history, they said they were continuing CellCept and stopping the tacrolimus intermittently. Probably I would have done that different way. I would have stopped the CellCept and just kept on the tacrolimus slightly, probably around 6-ish, 7-ish. Because many times people give a knee-jerk reaction. Whenever there is an infection, people try to fiddle with tacrolimus. They try to stop it, give a break for 3-4 days, and that's where personally I felt the problem happens. But I don't know. It's my personal feeling. You can tell your views.
So we agree too. So we do that, but in most of the cases, if we think of more on in terms of infection, we tend to stop or hold the CellCept and maintain a low dose of tacrolimus.
Manuel?
Same. Yeah, again, we don't use CellCept as much in these type of cases, but we would stop that first. In terms of if I'm worried of and again, for the meeting, right? In terms of, fever, this is the most common case we see around the world, right? With the recent review of 10,000 pediatric transplants around the world, more than 50% are going to be biliary atresia under 10 kilos under 1 year of age. So this is very important. And so obviously look at imaging, rule out anything else. Don't panic. I think what Naresh said is you can also see increase in your enzymes because of sepsis, right? So rule out that there's, not a biloma or something to drain, which you guys did with that MRCP. Maybe, I don't know if there was imaging before, but I would stop the CellCept first. And then if I'm not happy, then do a biopsy, probably a little bit earlier.
I think biopsy will be always, even if it is an infection, doing a biopsy will sort of help you with differentiating the cholestasis due to sepsis and a rejection. So I would have done a CT scan slightly earlier to look for any collections if the fever is still spiking, and I would have considered a biopsy much more earlier.
Imaging was done, CT ultrasounds were done. There was no collection. That's when we proceeded to MRCP, and we also took up for an exploration, thinking that the small fluid collection periductal in the MRCP might be contributing.
Because we have considered a biopsy quite earlier on, probably day 8, day 9, even with the fever.
Yeah, I think hindsight is 2020. We definitely have the advantage, but you had a tough call because you had positive cultures, tracheal, and then urine. But definitely, at the first 2 or 3 weeks, one has to be aggressive in working up, whether it's imaging or biopsy.
So this was after she got discharged. So she remained a bit okay with the bilirubins going a bit up, a bit down, enzymes remaining more or less slightly on the higher side. She kept having intermittent fever though. She kept having intermittent fever, which was high grade, 101, 102, on and off. So she was on amoxicillin on outpatient basis. She underwent, after that, she had a little bit of intrahepatic bile duct dilatation. So we did a PTBD.
Sorry, can I just stop you here? What was the inflammatory markers? You are saying still the child was spiking temperature.
Yeah.
Have we worked up for non-infectious cause for fever, like inflammatory syndromes? Because we do see inflammatory syndromes which can have high fever without a sepsis part. What is the inflammatory markers and the cultures being showing up?
The procalcitonin was close to normal in this patient, and CRP was around 8.
So we did a PTBD and a liver biopsy. And the second liver biopsy turned out with necrosis less than 50%, severe rejection, TCMR with RAI of 7/9. And she had some bile ductular reaction, and which was pointing to a bit of a biliary pathology as well this time. She underwent a second steroid pulse therapy, following which there was a fall in her bilirubin level, but it was not a sustained fall. We followed this up with basiliximab, and despite this, she kept having a rise in bilirubin.
So clearly, at this point, we were dealing with the rejection and versus the biliary pathology, but we didn't have any other evidence of for the biliary pathology except the mild IHBR for which the PTBD was done. But the trend of enzymes and bilirubin was still not settling, and we still, the repeat biopsy showed the rejection. So we treated with the steroid and basiliximab. So I just want to know from the panel, what's the ideal immunosuppression management in this setting with the patient?
I just want to share kind of our protocol for rejection is if it's, and we also, when you use BAF, so if it's mild, if it's 1 to 3, then we just adjust the tacrolimus, or again, we may add another agent, but usually just adjust the tacrolimus. If it's mild to moderate, 5 or 6, then we post steroids, usually 2, and then we see the reaction, 10 milligrams per kilo, or we may do another one, depends a little bit at how far from the transplant are. And then our protocol, if they have severe, if it's an 8 or a 7, 8, 9, and I think you had mentioned the previous 8, we use thymoglobulin. I have to say that we don't see very much of severe rejections as much. And the problem, I think sometimes, BAMF is the best way to classify, but I feel that sometimes when there's a biliary issue, sometimes the score can be much harder for the pathologies. And so these are tricky cases. One of the cases we did in December, we had a very similar problem, which was, a stricture, put a PTBD. It was very hard for us to get good TAC levels with the originally when we had open to a bag. And I know people talk about that with cyclosporin and supposed to not to be as much with tacrolimus, but I think it still happens. So you have to be careful with that also. If you have them on antifungals, make sure that. But if it's a real severe, we don't use basiliximab to treat rejection. At least in my center, our protocol is with thymo.
Dr. Kohli?
Yeah, we would also. I mean, I have worked at three different centers.
ATG having.
Sorry. Should I go ahead?
Yeah, please, Rohit.
So I've worked at 3 different centers, and it's interesting. Management of rejection, including steroid-resistant rejection, is different at Northwestern, different in Cincinnati and different here at LA. But we get over the hump any which way we try to do this. So there's many ways to skin a cat. Here in LA, we're doing, of course, 5 high dose. If you have primary ASER, 5 milligram per kilogram, then taper down really quickly, 4, 3, 2, 1. In Chicago, we used to do 10, 10, 10 mg per kg of steroids, and then go back to baseline. So it's different, but once you get into steroid resistant, then it becomes a little bit similar in the 3 experiences I've had. And we do tend to use ATG quite more, at least in my past exposure.
Dr. Shanmugam?
I think I haven't had much chance to use ATG. Probably a couple of times I have used basiliximab. But my take is, if the enzymes show, the AST/ALT shows 0 response to high dose steroids, practically whatever we do, it doesn't work.
Yeah, we've seen that doesn't work.
So if there is absolutely 0 response, because something else is happening to this child, whatever steroids, whatever we are trying to fiddle with, the bringing down, I think the immunosuppressing the child is not helping the child. So if I don't see a response to high dose steroids, practically whatever we do after that doesn't change the outcome.
I would have to disagree. I think we've gotten over steroid-resistant rejection with thymo quite often. We don't see it, but when we see it, we're able to take care of it, at least in the acute phase. Now, when you're dealing with high DSAs and you're dealing with AMR, that's a different story. That's a different beast. Then you're talking about plasmapheresis and bortezomib, and that's a harder nut to crack. But acute cellular rejection, early phase, yes, we see steroid resistant once in a while, but ATG works.
Yeah, ATG somehow for us has ended up with very high infectious complications. We have patients landing up with sepsis post ATG. So that's why we chose to go
Which, are you using Rabbit or Manuel, have you used, Rabbit?
Rabbit.
What dose? I think the other important thing is the dosage, right? I think for kids and for liver, the doses are probably much smaller than what I've seen my kidney colleagues use is always very high, right? And so I think for kids and even for adults, centers that use some ATG, I think the dose of the thymo should be a lot lower than. And just like you said, if after 2 it starts to respond, then just switch off.
So because she had rejection, not responding to treatment, the bile draining soon turned white, and the liver was not functioning at all. So at about post-op day 100, we decided to take her up for a retransplant in view of graft failure.
So I did, maybe I missed it, but did you have DSAs?
We had DSAs. DSAs were not raised for her. And C4D staining, we did immunohistochemistry on both the biopsies. It was negative on both.
Yeah, that I saw. Thank you.
Yeah.
Just to check with the panel, anything different we could have done at this point?
I've already said my piece. I think I would have leaned on trying to get over the steroid-resistant reaction a little bit stronger, but sometimes you cannot.
So
what I personally would have done.
Sorry.
With the sort of fever not subsiding, even on day 66, the child was taking 101. Probably we would have screened the child completely, even with a PET scan. And if we show that it's only an inflammatory response, probably I would have used immunoglobulin.
Thank you.
Which we have done a couple of times.
So she underwent a retransplant with the mother as the donor, group compatible, an open donor hepatectomy, again a left lateral segment graft with the standard venous anastomosis. She intraoperatively, although she didn't have any portal vein thrombus, intraoperatively the portal vein flow was very poor. So we augmented it with a cavo-portal hemitransposition, and the portal vein we opened into a segment 4 pedicle just to keep up with the portal inflow. The artery was anastomosed to a right artery, and this time we had a single graft duct, which we did a hepatocogenostomy for.
Dr. Manuel, your inputs for the timing and the surgical problems for the retransplant within 19 days or within 3 months.
Yeah, I think once the hardest part is always that first month, right, with everything. So I think 90 days is changeable is good. I think what you guys did was right. Obviously, be very open with the outflow. Your first graft had 2 outflows with that reconstruction, and oftentimes these grafts that have been going this inflammatory problem, whatever it is, rejection with a combination of infection, then they may be very swollen. So if you're getting a new graft, make sure that you open the graft, the outflow very much. I know in your first diagram you showed the right hepatic vein kind of closed and just a triangular to the cava, which I think is the way to do it. We go and make the triangle all the way to the right hepatic vein, almost like a. And then I think that I'm trying to understand the portal reconstruction here. Did you connect it when you said the 4? Is it like a Rex, or you just are you putting it when you mentioned segment 4? B,
So
are you
we
using
opened
kind
up-
of that entrance of the umbilical vein as a Rex? Because there are some people have reperfused the livers like that. I haven't done a fresh transplant, but I know that there's description of doing that directly, right? Going to that pedicle where the normal Rex would be years later. Is that where the inflow was?
No, so the inflow, the cut surface, on the cut surface, we had a pedicle. We had a large pedicle of segment 4B, which we had ligated. So we opened up that pedicle and we anastomosed it with that.
Yeah, and I have no experience with the hemi portal transposition to increase the portal flow. I would say that if the graft had been swollen for a while and I know with the short time it's hard to go over all the analysis. I would worry that with portal hypertension, there may have been some collateral issues from the original, very common on this biliary atresia. So before doing the hemitransposition on a kid, I never had to do it, we've done it in some adults, but I go and tie as much of the collaterals as we can to try to increase. And we like to measure the flows intraoperatively. And in some cases, we even we do a portogram just to kind of see that. So I think that, again, portal inflow is going to be very important to have a safe graft. And, it's not clear to me. I think the answer that you said, it is, once you go into this reaction that you start losing the graft, whatever the reason is very hard to get it back. And I think that retransplant was the decision in this place, if you have a donor. But I think have to make sure that all the technical parts are perfect. So I don't know if there was something else in the explant. Maybe you'll have time to share on that.
So I'll just run through it. Explant showed chronic rejection with areas of cholangitis and microabscesses. And post-retransplant, she had an uneventful course. She was discharged on the post-op day 11. It was on immunosuppression, levels were okay, no fever, no tachycardia. All bilirubin enzyme trend all down. She went back home. Surprisingly, on follow-up, after a month of the retransplant, all levels were above 7-8 tacrolimus, and mother noticed jaundice. So she came back to us again with rejection. We did a liver biopsy. This time again, it was 7/9. She got a steroid pulse. She responded to that. Enzymes were still up. We started her on everolimus this time. And with everolimus, she did pretty well. So that was...
So this was our first case where we have used everolimus for the recurrent rejection or steroid-resistant rejection after retransplant or any of these settings. So especially in the pediatric population. So I want to know from the panel any experience. We didn't find any literature available on use of everolimus in the pediatric setting. So if we can have some inputs from the panels.
Dr. Naresh might remember I had called you up regarding this case.
Dr. Naresh, you have to unmute yourself.
We use sirolimus, and usually we get run level of plus sirolimus of around 9 which should do. And usually when it's steroids, sometimes even we put on four drugs for like a resistant rejection, like including MMF, tacrolimus, and sirolimus. But it's only if it's not working, probably to take off one of the immunosuppressants. We can't children on immunosuppression.
Dr. Kohli?
No, we've not had the chance to use everolimus widely, no.
Manuel?
And we were part of the, and I don't know, Rohit, if you're part, we were part of, there was a multi-center study for pediatric liver transplants using like early switch, I think it was, I think it's 8-week switch to everolimus from tacrolimus. It was a combined, and this was probably like 4 or 5 years ago. It was probably 20 centers, 25 centers in the US, and it was never published because the study had to be stopped at the middle because of the high rates of CMV and EBV and in kind of the preliminary. So there's really have not been a lot of studies. We use everolimus in kids in mainly two things, in hepatoblastomas, especially if we're worried about the explant having, high risk than others, not a lot of necrosis, but we usually wait 3 to 4 months to do it. And one of my partners, Dr. Book, likes to use it late on. And again, on these cases where you have positive DSAs, and there's this question of, could this be AMR, which is kind of, we've been saying the new kid on the block, but it's been for a decade that people are describing more and more, but we don't know. There are some centers in the US, I think is Kansas and others, which automatically, if they're worried about antibody-mediated rejection or positive DSAs, they add an mTOR, but no experience early on like this case. I do think that there's a role. I think that we need to learn more. There's not that much volume in pediatrics, right? So that's why these multi-center studies are important. And
any final comment from any of the panelists?
Yeah, was sirolimus, because as Manuel was saying, we didn't have much of experience handling the everolimus.
Dr. Shanmugan, you are not audible.
See, why everolimus was chosen than sirolimus?
Okay, thank you. Thank you to the all the panelists. We will move to the next session.
I just want to make one comment. There was an American Transplant Congress. There was a session a few years ago that George Mazariegos coordinated. He did a survey, I think, of around 30 pediatric liver transplant centers in the US. As you know, we have too many pediatric liver transplant centers. And so, but it was incredible. I have the slide somewhere, because of 30 or 30 plus transplant centers, there were 26 different immunosuppression protocols. What Rohit said, some do induction with one, some with the other. So I think this is where we need to work together. We're a small community and try to collect data and do studies, multi-center and multinational, right? I think that through ILTS, to pediatrics, through IPTA, through the Society of Pediatric Liver Transplantation, because I think it's the only way that we're really going to get to answers, to have more data from multiple centers. So I think you guys handled the right way, and it was a great case. Thanks for the invitation.
Thank you. Thank you. We will move to the next session. Unfortunately, Dr. Yuri Genk is scrubbed in a case, so I'll thank Dr. Rohit Kohli to fill in in this for him. And Dr. Kohli is going to present on pediatric liver disease, what's new. Dr. Kohli is a chief gastroenterology, hepatology, and nutrition. He's a professor of pediatrics at the Children's Hospital at Los Angeles. And we have the esteemed panelists, chairpersons for this session, Dr. Neerav Goyal. Dr. Neerav Goyal is a senior liver transplant surgeon at Apollo Hospital, New Delhi. We have Dr. June Lee, who's a transplant and hepatobiliary surgeon at Shanghai, China. And we have Dr. Deepak Goyal, who's a director of pediatric gastroenterology and hepatology at Fortis Hospitals, Delhi NCR. So I would request Dr. Kohli to deliver his talk. Thank you.
Hi, can you see my slides? Let me know if you can see my slides.
Yes, we can.
Yes, yes, we can see them.
Perfect. So sorry, I'm not Yuri. So this will be a non-surgical talk. This will actually try to take you away from liver transplantation. But I hope you'll bear with me last minute. So what's new? Before we start, I just want to 30 seconds put up my disclosures, working with these companies for different either research support or consultation purposes. We'll be talking about a FDA-approved medication, but we'll be sharing data in hopefully an unbiased format. So we of course have unmet needs. We need to be aware of the long list of pediatric liver disorders that we as physicians, hepatologists, as surgeons deal with, and some of them when they are incompatible with life or with liver function, or some with liver being a part of dysfunction in another organ, like neurologically or developmentally, or renal function, we lean on liver transplantation to correct those dysfunctions or incompatibility with life. Of course, there's a big pie. We just talked about a patient with biliary atresia of cholestatic liver disease. As you can see, close to 60% of our transplants are sometimes done for cholestatic disorders, up to about 50% of which is usually biliary atresia. But right underneath that, one of the other cholestatic disorders is Alagille syndrome, and there's been a change recently in how we can manage Alagille syndrome. So I've been talking about what's new. So let's just focus a little bit on this disorder. So we see children, of course, with a lot of xanthomas in Alagille syndrome, and this is a child from our clinic where you can see some debilitating skin xanthomatosis. And on top of this, they have recalcitrant itching, very unfortunate. And going back in time, Alagille syndrome, one of the things that we would have done or still do to this day in children who have end-stage liver disease from Alagille syndrome is to do liver transplantation. So I think it was similarly timed in India, around 1998, 1999, Apollo in Delhi, did the first liver transplantation for a child successfully. Here in CHLA, we also started at about the same time, and we've done quite a few. Last year, for instance, it's not on this chart, we did about 31 pediatric liver transplants, and the survival curves have been great. We all hear justifying that existence, discussing the nuances of rejection management, but the big picture is there are a lot of smiling faces behind this. These children grow up. This is a picture of that child who got transplanted at CHLA in '98, and this is that lady now grown up in 2016, carrying another child who just got a liver transplant that year. So the question is this a cure? And not really, because we need to think about all the consequences. We just talked about retransplantation in a child. So it's definitely not a cure. We're dealing with infectious etiologies, and we're dealing with complications which are surgical or medical. So it's liver transplantation is a boon, but not a cure. So how can we avoid it if we can in Alagille syndrome? There was a placebo-controlled randomized trial of intestinal bile salt transport inhibition, specifically for what we just showed you a picture of, which is the itching. And so just to give a primer for people who are not thinking about this every day, of course, bile acids are produced in the liver. They get secreted from the liver through the bile ducts into the intestinal tract. And as we eat fatty foods, micelles are formed and bile acids are used in its absorption of fat through micellar formation. Whatever is unused, typically in the ileum, in the ileum, whichever way you want to pronounce it, 95% of bile acids that reach the ileum will be reabsorbed through bile acid reuptake, or what we call the enterohepatic intestinal liver recirculation. There's always been a correlation observed between itching in any cholestatic liver disease and serum levels of bile acids. So there was a new compound, a group of classification of compounds that came about through research of bile acid transport inhibition, or ASBT, apical sodium bile acid transport inhibition. And when we look at this particular product, where you have subjected it to inhibition through a pharmaceutical agent, maralixibat, at different dosages over 35, 70, 140, as you can see, days and dose. You can see the weeks at the x-axis and the changes of itching on the y-axis. So they used a scoring system, observer initiated, called itch row, and over the level of dosing, even if you leave aside for a second, overall, all of the doses see a decrease, and the doses which are triangle and square, so we're talking about 70 and 140, sorry, a star and triangle, 70 and 140 respectively, a significant decrease in the itch row scale over week 8 to week 13, which is the stable dose period, not escalation period, in this trial. There was an a priori set primary endpoint which was not met. However, there were differences, as I just went over, at the two doses of maralixibat at 70 and 140 microgram per kilogram per day. So one of the things that families really were worried about and concerned about, their children were not sleeping, they were itching all the time. We may have something, and that became sometimes an indication for liver transplantation. There may be a way out. So in February 2021, about a year ago, the US FDA gave breakthrough therapy designation based on these data to pruritus treatment with IBAT inhibitors in Alagille syndrome. And this is just another graph showing, table showing itch row decrease, almost 2.3 in scale after initiation of treatment. So there's 3 different disorders, not just Alagille syndrome, that this ASBT inhibition. There's another drug called odevixibat, which is a similar compound. It's in the same class. So odevixibat, maralixibat, both are now approved in the US. Odevixibat is approved for treatment of pruritus in PFIC, and maralixibat is approved for Alagille syndrome. There are studies ongoing with both of these compounds for biliary atresia. So how does this work again? So this is the reuptake inhibition site. So you're in the ileum and you're supposed to be taking up bile acids through these ASBT transport mechanism, but odevixibat, maralixibat block this reuptake, and you see reduction in pruritus, reduction in serum bile acids. And of course, there's a flip side to what happens inside the liver, where you have an increase in bile acid production. So 7 alpha, C4 levels go up, and what we see is that there is a propensity of bile acids to be produced by the liver being increased, because you're losing bile acids in the feces because of this blockage of reuptake. So there's been quite a few trials in Alagille and PFIC. I'm just going to talk through one specific trial called ICONIC. It was the trial that led to the FDA approval. It was a phase 2B study in specifically Alagille syndrome. And it's a nice primer as well in terms of putting together a placebo-controlled trial. So here you can see that initially everybody was on maralixibat, and then you get randomized to either placebo or maralixibat, and then you go back to maralixibat. It was a really interesting study design, and the reason was that the prior study had shown, which I just walked you through the publication, it showed such good efficacy without meeting the primary endpoint. It was difficult to put somebody on pure placebo. So children, of course, who had LGLs were placed on this. They shouldn't have had liver transplant or diversion. And this is just the age groups and JAG mutations being the predominant, exclusive in this case, marker of diagnosis. And they all had high serum bile acid levels, as you can see. Of course, we know that less than 20 should be normal, even maybe some places 10 is considered normal. So their bilirubins were also elevated, and so was their itch scale score. And this is the part where I would like you to focus on, the pink part, which was where everybody was getting the placebo or maralixibat. So there were two groups to compare. As you can see, the placebo group shot up in terms of, again, change from baseline serum bile acid levels. When you don't give an ASBT inhibitor, IBAT inhibitor, serum bile acids go back to as they were in LGL syndrome, very, very high. However, over time, because we were giving both groups long-term maralixibat, you can see serum bile acids going down. And this is the same thing for itching. Also, when you have the placebo group in red going back, the itching comes back to baseline. However, with maralixibat, especially long-term with both groups, you can see how nicely itching is controlled. And now that it's FDA approved, I've been able to use this in patients, and it's amazing how we've seen. Of course, there's different ways of looking at data. Here they're looking at the proportion of days with itch row scored less than 1. And this again, the red bars are when you were on placebo, the individuals, and they had gone down. However, overall, maralixibat reduced the itch row scores very nicely. So this is the same kind of things. This is an improvement in xanthomas. The picture I showed you, the debilitating xanthomas, the cholesterol deposits on the skin, they melt away very nicely with IBAT inhibition. More interestingly, this was a secondary outcome. You're seeing an increase in height Z-scores as well, significantly. So overall, something to think about. And of course, nothing comes as a free lunch. There were significant identified problems with these inhibitions. As you can imagine, if you are increasing the load of bile acids in stool, you will start to end up with diarrhea. And another signal that we're watching for is elevated liver enzymes, but whether that is true and above the normal variation, we don't know. So in summary, this is a new treatment modality possible, odevixibat, maralixibat, as ASBT inhibitors for Alagille syndrome and PFIC respectively, FDA approved, to specifically treat pruritus, but there are some secondary positive endpoint changes that we should keep in mind. So I'm going to stop here and see if people have questions.
Hi, Dr. Kohli. It was nice to know that we have we encounter a lot of PFICs and Alagille in day-to-day practice. So, are you using it routinely, this drug, for all cases of Alagille, or when you are stuck and the pruritus is extreme, then you are using?
That's a good question. Change in practice is hard. This is very, very new. We've only had this FDA approval for about 2 months now. So I've started some patients who were coming to me complaining that they've used all the other things that we typically have used for pruritus, and they have responded. So I'm getting more comfortable. But for me to say that I'm calling every LGL patient come in and get, or every PFIC patient come in and get an odevixibat prescription or a maralixibat prescription, we're not there yet. But to your point, when children are recalcitrant with their pruritus, we are starting to offer this.
Hi, Dr. Kohli. I'm Dr. Neerav here. Very interesting data. So you think how long will the treatment be? I mean, like, because in your trial, in the trial where the placebo was used, patients went back to having itching and raised and xanthomas and whatever, all the problems. So what is the duration of the treatment you think, and how cost effective is it? Why I'm asking is that we have had a couple of patients with multiple xanthomas, children, and PFIC, where we have done a simple bypass, cholecysto enteric colic bypass, and the itching has resolved, the xanthomas have resolved. So cost effectiveness, duration of treatment, what is your take on it?
No, it's a very important question. I don't think we have all the answers yet. Before these drugs came online, we were doing the same thing. We were talking about either transplant or PEBD. And yes, there are good outcomes, but they have their own complications. We all know those. We just talked about transplant, PEBD, especially in warmer climates like India, how much of a propensity to increased ostomy output and electrolyte changes. Even in Chicago, where it is not warm, I still remember when I was in training, we had done a child had just recently gotten external biliary diversion, and we discharged the child on Thursday, and Friday night I was on call, and at a 911 emergency call to the ER, the child had come in with hyponatremia and almost died on us by just dehydration. So I think everything that we do, definitely in these children, because these are genetic defects for now, until we get gene therapy, are going to have to be long-term. So whether it is liver transplant, that is long-term, whether it's PEBD, it's long-term, whether it's going to be these medications, as you notice, as soon as we switched to placebo for a week, it was back up in terms of itching and everything. So all of these answers will have to be long-term.
Has it been approved for PFIC as well as Alagille?
So the two different medicines, they're both ASBT inhibitors, but different compounds, slightly different. Odevixibat is approved for PFIC, and maralixibat is approved for Alagilles.
Any reason why? Any specific reason why two drugs for two?
It's basically the trials. The different companies that own these products, they did trials in those. So maralixibat was tested in Alagilles, odevixibat was tested in PFIC, and that's the data they presented the FDA, and that's how they got approved.
Okay.
All right. Any other questions? Anybody wants to?
There's a question, looks like in the chat, from Manuel. Do you have experience of post-transplant PFIC, especially in ones? So he's talking about PFIC1, and comment on cost. Yeah, so I think two very different questions, Manuel. Thanks for them. So PFIC1, we all know FIC1 deficiency. FIC1 is present both in intestine, in enterocytes, and in hepatocytes. So FIC1 patients with PFIC1, doing liver transplants on them is very controversial because you don't fix the intestinal problem. And when you don't fix the intestinal problem, you end up with post-transplant liver problems like steatosis, and actually end up with bile acid diarrhea as well. So my bias is completely stay away from liver transplant in PFIC1. I think we've done the experiment too many times.
Well, I tell you, the reason why I bring the question, Rohit, is exactly because, as you know, for the last 5 years in the new center that I'm at in Salt Lake now, I've encountered a number of patients that were transplanted 10 or 12 years ago for PFIC1, which, I trained with Ben Schneider, so it was like, no, you don't transplant, it wasn't the solution, but there are definitely, I think, before the knowledge that we have of the subtypes and everything, there are a number of kids, and we're facing this, right? Either they have steatosis and start developing fibrosis, or they have itching. And so I didn't know if, this question came up recently in a case discussion in our center. Can we try this maraliximab? And then, they brought up that, and I had no idea, these are drugs that you as pediatric hepatitis managed, but that it was very expensive, and because there's no post-transplant trials and most of the kids that we have it on in our center are in a study, probably one of your studies. And so we said in order to use it on something that had never been used or there was not enough, then it was very difficult to get. And I have no idea about the cost, but the pharmacies that were involved said, like, it's not cost effective, right? Obviously, we've been proponents, and we learn a lot from our colleagues in India of the internal diversions in the time of transplants or any type of diversion. But I think the internal, like Dr. Nirav was talking about those, I think it's great. It's interesting that when you talk to centers in the US, not a lot of people are doing them, right? And the ones of us that do them, they see like, oh my God, this is crazy. But I think in the rest of the world where you have more PFIC, you use it and they're effective. So I don't know if post-transplant these medications have any role, but I do think that PFIC first should not be transplanted. The ones, if you have to, then divert them.
No, diversion works, and we are doing internal diversions. We are not doing any external diversions, and they work very well.
Yeah, that's
very cost effective. Yeah,
I think there's a role. There's definitely a role for internal diversion. The issue becomes, of course, of what you're trying to treat in your local. So in terms of cost, for instance, Manuel's question, it may be more important to think about when you're paying out of pocket, especially in an Indian scenario. In the US, whether or not you have personal capacity to afford the medication, usually either insurance company or the third-party payers from the government will pick up. In this case, actually, Manuel, I would suggest approaching the companies, because they're newer medications. They're very supportive of their expanded access program, where they provide the drug for free. So we've had success with patients who the insurance companies denied paying for it, but we got it through the manufacturers through their expanded access programs.
Thank you, Dr. Rohit. If there are no further questions, we would like to, there is one more comment from Dr. Emmanuel. Go ahead, please.
No, just an invitation that the International Liver Transplant Society, AILBS, and through the leadership of Dr. Rella, that we've done these multi-center census that most of your centers participated. Actually, the Asia had one of the best participation, and the centers for India and all of you. And these census have been sent for publication. They're about to send the next one in the coming. But Dr. Rella had proposed to do sub-studies on certain diseases, and one of the hepatologists from Turkey, because I think the Turkish group also see a lot of PFIC, and Middle East is gonna start a kind of a special, and I'm involved in the ideas, but I don't know the details of the study in doing a multi-center data collection of PFIC post-transplant, and take all of them, right? The ones, the two, the three. I think every region of the world we see something a little bit different. And so if anybody's interested, I just put my email there, and I can send the information to Dr. Shikdam Arikan, who's gonna be the PI for this project. I think this is the type of diseases where we have to get together and study them.
Yeah, while we're talking about getting together, maybe I'll put in a plug for the meeting we're hosting this year. It's a TTS conference, the Studies of Pediatric Liver Transplantation. Come join us in LA for Split.
We'll be there. It's a beautiful place to have a conference. So hopefully there's no COVID by then. Thank you, everyone.
Thank you, everyone. Thank you, Dr. Rohit, for your wonderful presentation on medical management of pediatric liver disease and the newer perspectives. And thanks all the chairpersons for the session. We would now move to the next session. It's an industry-sponsored lecture on the consequences of immunosuppression in solid organ transplantation, and the speaker for which would be Dr. Giriraj Bora, who is the Chief Liver Transplant and Senior Consultant at the GI and HPV Surgery Department at the Artemis Hospital, Gurugram, India. And to chair the session, may I invite Dr. Ashish Singhal, who is a Senior Consultant at the Department of Liver Transplantation and HPV Surgeries at the Fortis Hospitals, Delhi, NCR. Dr. Giriraj, please.
Hi, am I audible?
Yes, you are audible.
But there's a screen, which is in front of my, slides. So is it from my side, or am I supposed to do something different?
Slides.
Do you have the slides?
Yeah, I share slides, but there is something coming over my screen. So share screen.
Let me check.
Yeah. Ashish. Hello.
Yeah.
Can you hear me now?
Yeah, I can hear you.
So
can you share?
Now it's okay. Can I start?
Sure. But can you share your slides, please?
I did. In fact, I shared my screen. Share screen.
Share your screen, sir.
No, which one?
Yes, we can see your slides now.
So I'm sorry for this. Glitch.
No, that's
sorry.
fine. We can start, please.
Yeah.
Thank you.
So I must congratulate, Team Fortis for organizing, regular conference meetings. And so I'm going to speak on consequences of immunosuppression in solid organ transplantation. And this particular presentation, it is sponsored by Novartis Pharmaceutical Limited. So we all know that, liver transplant or a solid organ transplant, in fact, have changed, lives of millions of people over the last few decades. And thanks to refined surgical technique and sophisticated immunosuppression protocols that have led to improved patient and graft survival. Unfortunately, even these modern medicines and wonderful drugs still have a side effect profile that has led to increased morbidity and mortality in a significant proportion of patients. So today I'm going to discuss 4 main complications that are secondary to use of immunosuppression after organ transplant. And this includes newly onset diabetes, renal dysfunction, de novo malignancies, and lastly, opportunistic infections. So first, talking about newly onset diabetes, we all know that it's a common post-transplant complication after organ transplant. And in fact, the incidence after solid organ transplant can be as high as 40%. And unfortunately, when it sets in, it has great, effect on graft as well as patient survival in the first year, with the risk of, complication or, graft-related issues much higher than the complications secondary to acute rejection. So what can be the consequences? So this is data which was based on study of approximately 11,000 patients, and what they found that newly onset diabetes is a strong independent predictor of mortality and graft failure after kidney transplant in those patients who develop it in comparison to their non-diabetic counterpart. Similarly, among heart transplant and liver transplant patients, if they develop diabetes, mortality has been 2 to 3 times higher than the recipients, who did not develop diabetes. So are immunosuppression real culprits? And so I'm going to talk about their diabetogenic potential one by one. So first, talking about steroids. So we all know that, corticosteroids, when used for prolonged time for any illness, has got diabetogenic potential. And what they do, I mean, they reduce peripheral insulin sensitivity and inhibit the pancreatic production and secretion of insulin. So, I mean, in a pooled analysis, what was found that the use of steroid followed solid organ transplantation increases the risk of newly onset diabetes by as much as 42%. Now, talking about CNIs and their role in newly onset diabetes. So CNIs are known to cause reduction in insulin secretion and synthesis, similar to corticosteroid. And in fact, the use of tacrolimus, the newer CNI, has got higher incidence of diabetes after its use as compared to the previously used CNI, that is cyclosporin. And what was found that tacrolimus has 70% higher incidence of newly onset diabetes as compared to other agents, as well as cyclosporin. And in fact, there has been some evidence that if you switch these patients from cyclosporin to from tacrolimus to cyclosporin, maybe one can achieve better glycemic control. So third agents, which are azothiophrin and derivatives of mycophenolic acid, fortunately, both of these do not have any association with newly onset diabetes after transplant. And lastly, talking about sirolimus and risk of diabetes. So sirolimus, similar to tacrolimus, has been associated with newly onset diabetes, and especially, this effect is more pronounced when it is used in combination with CNIs. And similar to tacrolimus, it increases insulin resistance and also impairs the beta cell response to various stimuli. Now talking about the second mTOR, which is EVR, everolimus. So everolimus fortunately has got lower association with the diabetes, and in this particular study, which I'm showing here, what was seen that when one arm of the patient who were on cyclosporin was switched to tacrolimus, they were found to have significantly better control of sugar as compared to those patients who were this effect, improved sugar control was seen to be, this effect was sustained over a period of 30 months. So maybe, we can add few modifications. That is, some of these patients, if possible, can be converted from tacrolimus to cyclosporin. And like in liver, where, we have adopted an early steroid withdrawal protocol. So if some of these solid organ transplants can find a way for early withdrawal, maybe we can have some better glycemic control in significant proportion of patients. Now talking about second toxicity or second consequences of use of these immunosuppressive medicines, and that is renal function decline. So we all know the frequent complication of solid organ transplant. And in fact, the risk of AKI after the use of these medicines can be as high as 56%, and unfortunately, up to 8% patient either become dialysis dependent or may need a second transplant, that is kidney transplant, if they want to be dialysis free. So we all know, we know that, CNIs have significant nephrotoxic potential, and this effect can be divided into two portions. So early after the use, maybe, as early as a month later, we find that there is rapid reduction of GFR. But this early change is reversible if the dose somehow can be reduced or it can be stopped, which is practically not possible in most of the cases. But over a period of time, there are structural changes in the kidney, which includes tubular atrophy, fibrosis, glomerulosclerosis, and unfortunately, at this stage, the changes are more irreversible. So CNIs are, we know, they are one of the main implicating factors for renal decline function after solid organ transplant. And unfortunately, it is impossible to have a CNI, or very difficult to have a CNI-free regime because of the effectiveness in reducing allograft rejection. But what was seen that if we can find a way to minimize the cyclosporin, this particular study has been on lung transplant recipient, and what they found that if with the use of CNI minimizing regime, they found that there was some improved heart function with some favorable cardiovascular outcome, but there was slightly increased incidence of biopsy-proven acute rejection. Now, sirolimus and sirolimus is an mTOR inhibitor, and theoretically, I mean, they are considered to be more renal safe as compared to CNIs. But in those patients who have significant proteinuria, pre-existing proteinuria, the sirolimus may have a nephrotoxic potential, and in fact, I mean, there has been the loss of kidney function significantly by use of sirolimus. So, as far as the nephrotoxicity of sirolimus is concerned, it can cause significant proteinuria, and in fact, that can cause a significant loss of kidney function over a period of time. Now talking about the second mTOR, which is everolimus, and everolimus has been tried with reduced doses of CNIs in a number of randomized controlled trials. And these two trials, I mean, which are here on the screen, they are on basically on kidney transplant recipient. And what was found that at 36 months of follow-up, there was no difference in the efficacy failure. In fact, there was no difference in the rates of biopsy-proven acute rejection, which was similar in both the arms, which is reduced CNI with everolimus versus standard sirolimus and a combination of mycophenolic acid. And the creatinine clearance was found to be significantly better in everolimus arm as compared to standard CNI group. Now, these are two important studies, I mean, which address the role of everolimus and reduced dose CNI. And the first trial, H2304, was basically for diseased donor liver transplant. And the second trial, H2307, was basically done in Asia, and was a living donor liver transplant trial. And both the trial compared the reduced dose CNI in combination with everolimus to standard CNI regimes. And what was found that efficacy of both the arms was similar. The side effect profile of both the arms, that is everolimus with reduced CNI, was similar to standard CNI regime. And in fact, I mean, there was some benefit in terms of kidney function that I mean, estimated GFR was significantly preserved in everolimus and reduced CNI group as compared to standard CNI arm. And this effect was found to be maintained at 24 months. So the advantages of everolimus with reduced CNI regimes can be, I mean, it has a synergistic immunosuppressive effect to CNI, and obviously, I mean, it has ability to use the lesser doses of CNI and some I mean, benefit in terms of preservation of renal function. Now, talking about antimetabolites, fortunately, I mean, they do not have any significant renal toxicity, and in fact, I mean, when used in combination of CNI, they can reduce toxicity by allowing the use of lower doses of CNI regime. Now, the third complication, that is development of malignancies. I mean, you all know the malignancy is the second most common single cause of death after solid organ transplants, and these patients, all recipients, unfortunately have 2 to 4-fold higher risk of development of malignancies as compared to general population. And what is more unfortunate that, I mean, these recipients with cancers have poor survival rate as compared to the general population of the same cancer stage. And the incidences of these malignancies like lymphoma and skin cancers is significantly high as compared to general population. So talking about the role of individual immunosuppressive agents, first talking about CNI. So CNI therapy has been shown to increase the risk of malignancy in a dose-dependent manner. And what it does, it causes stimulation of transforming growth factor beta and also increased production of pro-angiogenesis genetic vascular endothelial growth factor. mTOR fortunately has strikingly contrasting effect, and what it does, I mean, it has significant chemopreventive properties. So the mTOR inhibitors can cause interruption of anti-apoptotic effect and mTOR-dependent angiogenesis of regulatory genes that are essential for the development and propagation of malignant cells. And similarly, the mTORs have been found to be causing suppression of translation of messenger RNA that promote carcinogenesis. So sirolimus was used in heart transplant recipient in place of CNIs, and what was found that CNI-free regime with sirolimus was associated with significantly lower incidence of malignancies, and there was even the effect was more pronounced in terms of its effect in the incidence of skin carcinomas. Similarly, everolimus has been used as a chemopreventive agent, and a number of randomized control, a number of trials have assessed this effect. And in fact, the GEES trial, the largest study which compared the everolimus with CNI elimination versus standard CNI, showed that only 1.6% of patients in the everolimus group developed neoplasm as compared to 6.4% patient in the standard CNI regime group. Similarly, a number of studies has evaluated the role of everolimus with reduced CNI versus standard CNI as far as the recurrence of SCC following liver transplant is concerned. And the overall, this was a pooled analysis of two trials, S2304 and S2307. And the pooled data showed that the overall SCC recurrence was significantly lower with everolimus-based reduced CNI regime as compared to the standard CNI group. And this chemoprotective effect was more pronounced in those SCCs who were beyond the Milan criteria. So basically, the everolimus-based regimes are associated with significantly lower rates of SCC recurrence versus standard CNI therapy. And the EVR reduces, everolimus basically reduces the risk of recurrence of skin cancers. And what has been shown that, everolimus-based regime showed reduced numbers of newly onset malignancies in liver transplant patients compared to those on standard CNI regime. But, there is a caveat that monotherapy with EVR, even with a reduced dose of CNI, has slightly higher risk of acute rejection as compared to standard CNI regimes. Now, the last complication, which is opportunistic infections, we all know that solid organ transplant recipients are increased risk of developing various bacterial, viral, and fungal infections. And steroid, I'll start with the steroids. Steroids cause a negative effect on the immune system and increases the risk of bacterial, fungal, viral, and various fungal infection. Fortunately, mycophenolate, unfortunately, mycophenolate though do not have any renotoxicity or diabetogenic potential, but like other agents, they also increase the risk of cytomegalovirus following solid organ transplantation. EVR, similar to other agents, the risk is a real concern, and the same has been shown in the PROTECT study as well as in RESCUE study, that the rate of any infection in the EVR group has been shown to be higher than the standard CNI group in both the studies. And these infections largely were oral herpes, sinusitis, and wound infection. Similar to, its chemoprotective properties, the use of everolimus has got some protective effect also, like risk of CMV as well as, BK virus infection by the use of everolimus has been shown to be slightly lower as compared to standard CNI regimes. So to summarize the way ahead possibly is balance. That is, too little immunosuppression can lead to acute rejection as well as graft loss. On the other hand, too much immunosuppression can lead to newly onset diabetes, nephrotoxicity, malignancy, and lastly, the higher incidence of infection. Solid organ transplantation is a life-saving procedure for many patients with irreversible end-stage disease. We all know that. Adequate immunosuppression is critical to the patient and graft outcome, with induction, maintenance, and rejection therapy being key to positive outcome. Although they have a pronounced side effect profile, calcineurin inhibitors or CNIs are still the backbone of early and late phase immunosuppressive regimes because of their proved efficacy. However, CNI-induced nephrotoxicity is a cause of concerns and can cause significant morbidity and late mortality. Therefore, the CNI sparing or minimizing strategies need to be implemented to overcome the CNI-related side effects. Studies have established a role for mammalian target of mTOR inhibitors, basically in the most solid organ transplant recipients. Minimization or elimination of CNIs while using mTOR inhibitors like everolimus, which acts through mechanism complementary to the CNIs, achieves a synergistic immunosuppressive effect that is not nephrotoxic. Thank you. I'm sorry, Ashish.
Thank you, Dr. Bora. It was nice presentation. I know that this is sponsored by Novartis, but a question for you. In my opinion, especially in the patients with HCC or with malignancy, it's more the lower dose of tacrolimus which matters in reducing the incidence of recurrence, rather than the direct effect. Though the mTOR do have anti-tumor effect. What's your thoughts on that?
Look, obviously, we use everolimus if the cost is not a concern. That is obviously a concern. In Indian scenario, you will agree with that. So if cost is not concerned, obviously I use everolimus. We use everolimus with all the SCC patient. As far as our protocol is concerned. But to say that there is a direct correlation between nephrotoxicity and reduction of, malignancy, that point I'm not very, sure about.
Okay. All right. Do we have any questions from the audience? Thank you. Thank you, Dr. Bora. I know this is Saturday night. Everybody is
No, it's not Saturday night. We are in a very messy transplant, Ashish. That's why I have to go back.
That's fine. All right. Thank you. Thanks for joining us.
So, all right. Thank you, Ashish. Thank you. Okay, bye-bye.
We'll move to next session, and that is a industry-sponsored lecture by Astellas. And this lecture will be taken by Dr. Ashish Singhal. He will be speaking upon immunosuppression post-liver transplant, present and future. And the session will be moderated by myself. Ashish, over to you.
Good evening. I know it's everybody is rushing, so I'll be quick. It's an immunosuppression post-liver transplant, present and future. The slide has been it's not moving. Yeah. So slide has been provided to me by Astellas. The session is sponsored by Astellas. So I'm going to discuss about the need of immunosuppression and immunosuppressants, current challenges in immunosuppression, and we'll talk briefly about the modifiable risk factors we have and how can we tackle them in our day-to-day clinical practice. We touch base on donor-specific antibodies, how important they are, and make some changes in immunosuppression while we are going through the COVID-19 pandemic from last 2 years. And definitely we'll have a final word on what's in the pipeline in the future for immunosuppression. So we know all that the rejection means that the body immune system attacks the donor cells, and it's harmful for the new organ. And definitely we have medications which curb the immune system, and all put together they known as immunosuppressants, and which is definitely is essential for preventing or treating any kind of rejection, whether it's hyperacute, acute, or chronic. And definitely to prove that based on clinical diagnosis or for confirmatory, the biopsy is the gold standard. And if we talk about in liver or kidney, we follow the daily serum transaminases, bilirubin, alkaline phosphatase, and in kidney transplant about the serum creatinine and urine protein and serum protein creatinine ratio. But having said that, the biopsy is always what we need and rely on and treat the rejection if once there. Definitely the immunosuppression comprises of induction and maintenance therapy. Maintenance therapy is based on individual protocol at the center, including the dual, triple, or quadruple therapy. There are many centers which have come up with only the monotherapy with the tacrolimus or single dose or once a day tacrolimus also. So at our center, we follow the triple immunosuppression therapy for the first 3 months, and by the 3rd month, the steroids get tapered off, and then patients continued on tacrolimus and the mycophenolate. We hardly is using cyclosporin these days, but in cases patients have neurotoxicity because of tacrolimus, we do cyclosporin, and in patients with the patients with the HCC or renal dysfunction, we try to involve the everolimus at an early stage in the maintenance immunosuppression. This is a study H2307, which has around 38 liver transplant centers across Asia, which has included transplant centers from India. The patient recruited around liver transplant patients from September 2013 to October 2016. And it has two arms, everolimus with reduced TAC in around 142 patients and around standard TAC patients around 142. It's 1-to-1 randomization. And the steroid got a minimum 5 milligram of prednisolone for at least 6 months. And none of the patients get mycophenolate after the randomization. The tacrolimus, the level was maintained around 3 to 5 once AVR has reached the target trough level, and TAC level in the standard dose level was maintained between 8 to 12. This study showed there was a comparable efficacy and better safety with standard dose of tacrolimus regimen versus the patients who received everolimus plus reduced TAC. And what that study shows that the patients who got everolimus, they have more adverse effect, drug-related side effects, including hyperlipidemia, leukopenia, infections, and new onset diabetes at the 1-year follow-up. As we know, the development of immunosuppressive regimens starting from 1960s or 70s, from azathioprine and steroids to the late 90s, early 2000s to tacrolimus and mycophenolate, and lately we have mTOR inhibitors from sirolimus to everolimus. And induction therapy, as preferably most of the centers I know that they use steroid as the induction, but there are centers which use starting from ATG to, and these days there's a lot of buzz around basiliximab in patients, especially with the renal dysfunction. There are different targets of immunosuppression ranging from the CNIs, tacrolimus and cyclosporine, to IL-2 receptor blocker from basiliximab. Mycophenolate and azathioprine, they act on the purine synthesis, inhibiting the DNA replication, and the steroid, definitely they are the level of at all levels. So what are the challenges in immunosuppression, and what we're dealing with is non-adherence or intra-patient variability and under immunosuppression. There was a paper published by Dr. Newberger in 2017, and he has shown that the non-adherence, intra-patient variability, and under immunosuppression or over minimization of immunosuppression are the most common and major modifiable risk factors we can correct, and they are the major source for the graft loss in these patients. Non-adherence is background among the transplant recipients in our clinical practice. The patient who is in teens or young age, they are more tend to be more non-compliant, or a patient who has been diagnosed with alcoholic liver disease. So it's one of the very common, and especially in the first months after transplantation, and definitely if it's there, then it increases after in a long term. There are patients who we can identify those who missing successive doses or missing the occasional dose, or maybe not taking the right time or not taking the right dose. So there are different levels of immunosuppression we need to identify, counsel them, and correct them to prevent any rejection episodes. If you talk about the prevalence of non-adherence, different papers and literature has suggested ranging from 12% by Morales in 2012 to around 73% by Stiley in 2010. There is a suboptimal immunosuppression which we end up with the non-adherence, and that lead to early graft loss. And if you compare these patients, definitely there is the graft loss in these patients. There are the common recommendations for how to manage these patients with the non-adherence. They should be regularly monitored, and then there should be clinical awareness to identify the risk indicators like drug concentration and the drug levels, or indirect markers like the emotional, mental status of the patient or financial status of these patients too. The patient has to be counseled and recounseled about the adherence and the importance of that. And definitely the simplified drug regimens, which has a fixed dose, once a daily recommendations, which may help us improving the adherence in these patients. So if we talk about the incidence of graft rejection in liver transplantations, then if drug levels are variable, then there are more chances of biopsy confirmed rejection versus which don't. So if we talk about the CNI trough levels, it should be as a clinical practice, we do twice a week for the first 2 weeks after the patient get discharged. Then it goes to once a week for first another 1 month, and then goes to every 2 weeks, and then after 3 months they can get every once a month levels from in the long term. Definitely, if we talk about these patients, then if we can convert these patients from tacrolimus BID dose to tacrolimus Q once a day or Q day, then it will be helpful in these patients for a better adherence to the levels. Avoiding the significant variability is strongly recommended, and even on clinical practice, we also seen that if the patient change the brand of the immunosuppression, that also result in the different levels and can increase the chances of rejection. So if you talk about immunosuppression, that can lead to graft loss, and it has shown that it increases the histological acute cellular rejection and increase the likelihood of alloimmune response. So, and these patients have an inferior graft survival once it happens. So, so how once a day tacrolimus can help in tackling challenges in immunosuppression? There was a study published by Beckbaum in 2011 to show that once a day tacrolimus improve adherence compared with tacrolimus twice a day, and it was 66.4% in twice a day compared to 30.9% in the incidence of the non-adherence in these patients. So there was a 54% reduction in the non-adherence in these patients in once a day therapy. So if we talk about the once a day therapy versus twice a day, then it is there are twice a chance that the patient miss lesser doses in patients who get a once a day therapy in this population. Once a day therapy also reduces intrapatient variability and increase the exposure versus the patients who receive the twice a day tacrolimus therapy. If we talk about the ELTR data, the 4-year graft and patient survival, the once a day therapy versus twice a day therapy, there was a better chances of graft survival, around 6% difference. And if you see the patient survival, is a difference of around 5% at 4-year follow-up. What about donor-specific antibodies? We have not paid that much attention in the liver transplant as we see in our kidney patient. But there's the upcoming data, a lot of talk about the preformed DSAs and de novo DSAs, and so the risk factors for preformed DSAs is definitely the many blood transfusions, females, prior pregnancy, high risk patients, high MELD score patients, autoimmune history, or a history of recurrent viral infections, which can mimic the antigens or molecular mimicry. Definitely the retransplant patients are always at the risk of the preformed DSA and higher chances of AMR in this patient population. De novo DSA, if you maintain a low CNI levels, cyclosporine over tacrolimus, a lower MELD score, pre-transplant, and a younger age. So if we talk about the de novo DSAs have a negative impact on a graft survival or patient survival, there was a study by Kaneko published in 2013. Patient who has a de novo DSA, it shows a reduced 5-year survival by 6 to 7% both for patient and graft survival. So, so COMET recommendation also recommend that we should screen for DSAs in attempt to strongly minimize immunosuppression. If DSAs are detected, then definitely we need to be cautioned about reducing the further immunosuppression. COVID has taught us a lot, but we also have to learn about the immunosuppression in these patient population. In a clinical practice, not much has been changed in our tacrolimus or minimization. Definitely, if we have patient with the post-transplant COVID, we stop with mycophenolate and maintain on tacrolimus and steroids. That's, I think, that change in a clinical practice we have. And definitely, if patient has a COVID before transplant, then we will maintain a low level of tacrolimus in this patient post-transplant. But there is not data too much on this, and there is no data on the non-adherence in these transplant recipients. Immunosuppression, there are a lot of guidelines from Indian Society, from NOTO, from LTSI and ISOT, and definitely there's a dose adjustment is required, and to control and make sure that we balance between the infection and rejection. Definitely medical adherence strategies are required about the counseling and the telemedicine to to make sure the patient is having a follow-up and maintaining the levels and taking the drugs at the right time, and need to have keep regular reminders for that. Future perspectives, the goals are the improving long-term patient graft survival with a functioning graft. We need to increase the number of donors and improve number of function, immunosuppressive regimens. I have to talk about improved quality of life. There's evolving data about AMR and the new medication in pipeline for that. Definitely, there's always a risk of recurrent post-transplant infection and PTLD, and we have to prevent that by maintaining the adequate level of immunosuppression. So there's a personalized immunosuppression which is in pipeline, including genetic polymorphism. There's a CYP3A5 allele which was protein, and it's a higher prevalent in patients who are Black and Asian patients compared to the Caucasian. And if we talk about tacrolimus dose higher is required in these patients because of the presence of allele, so to maintain the therapeutic or trough level. Treg based cell therapy, this is alternative for future, and to infuse the donor specific Tregs in which can help in reducing the immunosuppression medication in future, and that definitely can prevent us from the side effects of immunosuppression. In summary, the non-adherence, intrapatient variability, and underdose immunosuppression are the main modifiable risk factors for the and challenges in the immunosuppression post-transplant. The trough levels of the immunosuppression should be regularly monitored to assess the medications, non-adherence, and variability. The dosing compliance may be reduced by reducing the pill burden by using the once-a-day tacrolimus versus the twice-a-day tacrolimus. And we need to be more vigilant in screening for DSAs in patients who are having, especially with the patients who are getting rejections without adequate immunosuppression levels. And definitely, we need to be learning about the challenging patients with COVID and managing their immunosuppression after the transplant. Thank you so much.
Thank you, Ashish. Very small question. Is there any difference in the incidence of rejection when we compare the patients who are on the tacrolimus and the patients who are on the once-a-day tacrolimus? That's
So, see, the data has shown that there is no incidence of or the difference in the incidence of rejection in once-a-day therapy versus the twice-a-day therapy. Definitely, the once-a-day therapy has the added advantage of renal function and maintaining the trough levels.
That's a better adherence and better tolerance of the patient. Thank you. Thank you very much. We'll move to next session. That is an industry-sponsored session. This is on recent advancement in advanced energy sources. This lecture will be taken by Mr. Puneet Rai, who is a Group Product Manager, All India Energy Portfolio, Ethicon Endosurgery, Johnson & Johnson. Thank you.
Good evening, all. Thank you for this opportunity, and good evening to all the delegates. I'm grateful for this opportunity. So my name is Puneet Rai, and I lead marketing for the Ethicon Energy Solutions in India. I know this is the last session, and I'll just take about 8 minutes to briefly take you through the recent advancements in the energy solution. And I'll particularly talk about a particular product, which especially is going to be of great use in the HPV space. So let me just share my screen and quickly jump into the topic. So my topic is going to be advancements in energy sources. And if I really have to put it in context, what is the significance of using advanced energy in today's world? Of course, there are clinical values that can be derived by the surgeons with respect to the procedures being safer, with lesser thermal spread. The dissections are safer near the critical organs compared to the traditional electrosurgery. And of course, there are patient values like less traumatic and safer, surgeries, less trauma on the tissue. So, the post-op pains are much lesser, the recoveries are much faster. There's a health economic value with respect to, these energies, because these energies actually enable shorter OR time, faster reduces the length of stay, so faster turnover of hospital beds. And of course, finally, the surgeon value is there in terms of convenience, in terms of shorter OR system, shorter OR times, and comparable complications. So all in all, advanced energy enables less traumatic, safer, cost-effective surgeries for patients with less pain and complication. And this is one reason why we do it. And at Ethicon, we are the market leaders in the advanced energy space, both in India and abroad. And number one thing that sort of drives us to enable it is the objective of making patients heal faster. And how do we do that? By bringing in energies which are less invasive in nature, because if the energies are less invasive, there will be an optimal tissue effects, minimum thermal damage and impact on tissue, which can result in lesser blood loss, reduced complications, reduced seromas, reduced nausea, lesser inflammation, and quicker return to work. So with that, with this objective, we have been constantly innovating our energy sources. Here, I'm just showing you quickly the journey that we have taken from a very basic ultrasound back in 1988, when nobody was even talking about ultrasonic energy. It was all electrosurgery. And over the years, with the same objective of making patients heal better, faster, we have continuously made incremental innovations to reach today, where we now have ultrasonic energies which can do everything. They are the devices which can perform as a dissector, as a sealer, as a grasper, as a automic creation, as a backscoring, everything is possible with the ultrasonic devices. In this next 2 to 3 minutes, I want to specifically talk about one particular device, which is the latest innovation, and we call it HD1000i. Let's first understand, what were the challenges at the HPV space with respect to the HD1000i. If you really look at it today, the complex procedures, especially in the HPV space, place greater demands on surgeon and their instruments. They need extensive dissection due to adhesions from prior surgeries, challenging tissue planes, and difficult to reach anatomies, right? And then they have many instrument exchanges throughout the procedure, which can add time and disruption to a case. As per the data, a standard hepatectomy, the median case length that was found as per the Premier database in the US was about 5 hours, and the complicating condition rate was up to 45%. Of these cases were complicated, and average instrument exchange during these procedures was 375 per procedure. So these were the challenges that were posed to us, and that's when Ethicon put us together and brought this HD1000i, which is the latest offering from an harmonic portfolio perspective, which brings unmatched precision, unparalleled strength, and unseen efficiency so far. From a device perspective, it gives precision like a mechanical dissector, because its jaw mimics the shape of a mechanical dissector. It has there is no need to use any other dedicated dissecting instrument if you have HD1000i in your hand. The strength of the seals that it produces, it's very, very reliable and can be used in challenging conditions as well. And efficiency, with the increased sealing speed and the softwares and the technologies that we have brought in, with this, it brings in the multifunctionality. So be it backscoring, be it sealing, dissection, automic creation, everything is possible with this simple device. And if you just look at this device, the first thing that you would notice is the jaw. It mimics a dissector, and at the same time it gives you finer dissection. At the same time, it gives you stronger sealing as well. The 18 mm blade gives you that functionality. There is an intuitive handle to it, and there is a dedicated button, the green button that you see, which gives you the capability of sealing up to 7 mm vessels as well. And of course, it has an integrated transducer to it as well. So it is just like a plug and play kind of a device. I had a video, I'll skip that, and I'll just move to the evidence part, because while we have created a device which should work, but the evidence also is now favoring us that this is the device to go for complex procedures. What we have found, basis the testing and the research and the evidence that so far has been generated, is that HD1000i offers efficiency, strength, and precision needed in complex liver procedure. It gives you that optimized efficiency for parenchymal dissection, especially during hepatectomy or partial hepatectomy procedures to improve surgical efficiency. It has shown to give reliable seal and transect intrahepatic vessels during hepatectomy and partial hepatectomy procedures. What we see here in the chart is the burst pressures. It gives the burst pressure up to 1878 millimeter mercury, which is much beyond the burst pressure required, but is also one of the highest that is available in currently in all the energy devices. The bottom one you see are the closest competitors from the burst pressure perspective. And if you see, this is the superimposition of a harmonic HD1000i over a Maryland dissector, and you will see it actually mimics the Maryland dissector. So it gives you that premium dissection in an energy device. So you pretty much don't need anything else from a comprehensive instrument perspective. From a harmonic technology perspective, of course, it has a harmonic technology backing it. It has shown superior clinical advantages in hepatectomy, especially. It has shown 55% reduction in blood loss compared to the conventional technologies like electrosurgery. Decreased intraoperative time up to 73 minutes in the procedures have been resulted with HD1000i and harmonic use. 19% reduction in complications and 1.5 days shorter length of stay. And on the right, there are few studies which are proving and sort of giving the evidence behind the numbers that I'm showing here right now. So all in all, I just want to end with saying that HD1000i is the device primarily designed for complex procedures. For all the delegates and everybody out there listening to me, I would definitely say that ask for a demonstration of this device from your ethicon representative, whoever is meeting you, and you will definitely see that this device brings a lot than just being a simple energy device in your procedures. With that, I'm just going to stop share, and if there are any questions, I'm happy to take. If there are no questions, I'm good to
Mr. Rai, question. So we are using your HD1000 shears in our laparoscopic donor hepatectomy. Cost. So I know this is maybe out of your purview, but I think I would always think that from Indian market, so based on the market, like in the Indian scenario, it's very difficult to justify the cost and every single donor. How can we get around that?
So, sir, you are absolutely right that from a cost perspective, definitely in Indian conditions, we do find that as a challenging aspect. There are ways, in which how we have seen some of the institutes within the country who have made the maximum with the same device in multiple cases, by having a dedicated generator. So there are certain tactical things that can be done, but in a long-term perspective, we are looking at technologies for the developed markets where there could be just like a shaft which will be just replaced, so that just all for the next procedure you just have to replace the shaft, and you go on with your procedures. Those kind of technologies we